hello, 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 mic testing, hello, hello, check, 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 hello, 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 check, 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 hello, 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 check, 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 hello, 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 check, 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 hello, hello, mic testing, hello, 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 mic testing, hello, check, 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 hello, 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 check, check, hello, hello, check, hello.
Congratulations, Prasad and Raju. And of course, you can see the full row of. Can you move the. Very, very well trained to introduce the case. Anuj?
Hello. Uh, we have 55-year-old lady, chronic hypertensive, dyslipidemic, hypothyroid. She presented with rest angina, was treated as non eccentric lesion in the month of February in 2012. This is showing the 2.75 by 23 drug-eluting stent. This was in 2012. Again in June 2014, she presented with dyspnea on exertion, class 3 NYHA. Check shoot done in 2014, August 2014, showed these lesions in the distal LMCA, instant restenosis in LA. NYHA class 2. ECG shows a normal sinus rhythm, left axis deviation with T wave inversion in anterior. Is preserved with grade 1 mitral regurgitation. Her refusal for CABG surgery has led her here. With that, I hand over the mic to Dr. Matthews and Dr. Menon.
Underwent the angioplasty for the LAD in but ostium of the ramus had some haziness, that's all. Yeah. Next.
So you have the trifurcation lesion, yes?
That's right. We have a trifurcation, and we have yet to decide what whether it is going to be 3 stents, 2 stents.
The first stent
Definitely minimum of 2 stents.
the first stent was implanted from LAD through the to left
In the LAD.
only.
Previous picture. See that nasty restenosis of the angulation, pinched.
Venous graft to LAD instead of Lima, which is a routine. Do you know why not for left anterior, left internal mammary artery?
He did not go for surgery. Now we have 2 wires. Previous pictures of 6 to 9 o'clock. Little under the growth. See, we did a IBIS run from the circumflex also. Millimeter artery, slow. And protruding into this. Across the ramus, which has got a very tight lesion. So that means wiring of the ramus is going to be very, very tricky. You have to get the wire into the, it is going to be the technical challenge. This part, because it's going to be difficult, I left it alone so that we can do it together. Are you able to see the wire tip? May enlarge it, please? No, I don't think you can.
Take short on this.
Focus it back. I have kept it all set, and let us see whether we'll be able to do it.
Get the balloon.
So you have the one wire in
I've taken a Xeon blue.
wire in circumflex, and now you would like to enter the intermediate, yes?
Go to earlier quarter. That's right. And that we saw from the IVUS that we have to avoid the struts, otherwise it will be going to be difficult. Okay, small test. I'm taking. Okay.
Sorry.
Small test. There we go.
Great,
Save that. Show that picture again. See, we have got a sharp bend, go into the circumflex. I am pulling back slowly, making the tip look upwards towards the ramus, and allow the tip to fall into the
Technique of wiring of intermediate artery.
loaded on that. It crossed very easily because we are not in the struts. We are just dilating it. The NC balloon from Meril, it's a good balloon. I'm sure all of you are very familiar with these devices of Meril. Okay. Now what do we do? What is the strategy? You want to advise me on that?
Are you planning?
Yeah.
Are you planning to use drug eluting balloon for the restenosis lesions?
I am not very comfortable using the drug-eluting balloon because I have not seen fantastic reproducible results. Here, partly because the stents selected, the stents are under-deployed definitely proximally. That is where the maximum restenosis is. So I would go and redeploy the old stent properly, maybe use a cutting balloon and you use a 3 cutting balloon and inflate it well and implant the stent properly, and then come back all the way into the left main. Now I have, once I use the cutting balloon, I will use the also slightly better, because an osteal lesions generally,
After cutting balloon, you plan to go with the first stent to intermediate artery or to LAD? What is your strategy?
probably the LAD first. From LAD we will stent into the left main.
It is an interesting
There is
question.
one
If-
thought.
Yeah, we just discussed done 3 years put only to LAD ostium, but through LAD ostium to left main. It is maybe better for avoiding resting disease. What do you think?
That's
You will put a second layer of metallic stent.
Now.
that lesion better go up.
Dilate the LED, no?
Using cutting a balloon for lesion preparation is better than some people believe that it maybe improve the results, at least the initial result, before stenting.
Yeah, I mean, I believe that it would improve, especially in an osteal lesions. Now what we'll do is we'll go and dilate the LED. We used it up in the, if it doesn't cross, then I will,
You are going with the
I'm
same,
going into the LED.
you are going with the same cutting balloon to LAD, yes?
That's correct, if I can get through. Okay, go ahead. Go ahead. Yeah. Six.
Okay. And how much atmospheres you use? Because there are also divergence.
About 10 atmospheres?
We are, you go ahead.
We've gone up very slowly up to about 10 atmospheres at this point of time. The nominal is 6.
Okay.
Yeah, but more. On the other hand, balloon and
There was rotablation in bifurcation that you have to do the rotablation first. For the diagonal, you have enough space to do that.
That's
for stenting only LAD, you did cutting with your cutting balloon. So I understand you,
Okay.
You would like to attempt this lesion as the first lesion to be stented, yes?
Yeah, what I was thinking is I would do is the LED we will stent with a shorter stent, maybe a 24, and then take a 4 millimeter stent for the left main, overlapping onto the LED stent is what whether do a mini crush for the ramus and then implant the stent, because technically I have a challenge which you have seen that the ostium of the ramus is a bad origin. I could not get sufficient dilatation with a normal balloon. I had to use a cutting balloon. That means I have mechanically produced a controlled dissection there. So this combination may limit my access into the ramus once I stent the LED. What do you think, Ajit?
And the only that's the only issue is the ramus
Circ access becomes
difficult.
okay. I hope everybody, I mean, you have followed. Ajit feels that, that ramus actually originates from the left main. It is partially from the circumflex ostium. Can you show that elaeocaudal? See, go forward. Okay, play. You see this picture.
Hello?
Yes?
Losing connection.
I mean,
We
once
can hear you.
After you've treated this ramus, I mean, the images show it comes off from the proximal surface, as pointed out.
Yeah, we think that it is
Yeah.
rather high marginal branch at the real intermediate branch. So it originates
Correct.
from circumflex, not from left main. Do you agree or?
Absolutely, that is giving us the trouble. That is. I will take now. We have dilated the whole lot. I'll take one more elaeocaudal picture and show you. Come to elaeocaudal. Then we'll decide.
Remember the wire pulling it. It is what we have. So, what is your general the predilation and cutting of this lesion? Do you want to use, I don't know, a culotte
we-
or brush or
We
advisory board, but there is an async different from LED to left main and from the circumflex to left main. Then using maybe only a balloon to redilate the ostium of the intermediate branch, but it is only our proposal for you. So
Well, your other option is
to me,
your left main didn't look much. You
you-
didn't have much disease on your nivus, so you can sort of do a V stent as well.
Okay.
And then follow it up with the balloon into the intermediate as part of that.
once we put a V stent, there will be a tremendous technique. The stent of the circumflex and LED will be meeting at the point of the origin of the ramus or the OM1. That time to recross with another stent will be a very, very major hassle.
also you would expect my opinion, the same what happened after the ostial stenting of LAD, that you will have a second restenosis. The chance for this is high with this
Absolutely.
technique, in my opinion. So I would rather
You're correct.
technique which assumes that you put your stent from LAD or any other vessel through the left main. Bifurcation or trifurcation of the left main into left main.
That is.
Remus.
Okay, what I'm going to do is I'm going to fix the mid LAD first. Then primary aim is to protect the LAD and get an optimal result. And then I would go for the circumflex, fix both of them, and then finally I will try to reaccess the ramus. If I fail, that's acceptable, but I need the I need the patient to do well.
Flex and the remus, let's say, is not so much important.
Okay. 24, 324.
You are French guy.
With a 7 French guiding catheter. I have a left side access also with me.
So you have.
If by any chance I have to use a balloon pump or a three balloon dilatation, I will have an access from the left also.
Okay. So with this 7 French guiding catheter, you have the possibility to do, if necessary, V-stenting with two stents at the same inflated at the same.
Absolutely. We have all, and especially manage.
Most of all, we are from the radial approach also.
I agree with you.
Point of view, it is very important point. You just said, Jacques, that 7 French for left main bifurcation lesion or distal lesion is much more safer and give you possibility to use different techniques. 6 French is maybe for left main shaft or ostial lesion, it's okay.
Going up?
You need large bore, you know,
For me,
to be comfortable.
left
You know?
main lesion is
Stent. 11
what was the deployment?
11 atmospheres. Now I'll pull back a little and deploy it a little better. 12, 13 is a very trackable stent, all of you have seen without any difficulty. And from IVUS we know that vessel size is
Open.
see because
Millimeter or 3.5.
If you are stenting, so what is your opinion?
very high pressures nowadays to implant. Seven, eight, nine. Mind you, part of the stent, the LAD. I'm going proximal part. Here, the LAD.
So can we see now the projection which will be?
We'll do that. We'll do that.
Well, what do you think about the concept to redilate again the ostial of ramus before you put a stent to circumflex? Or you
I
think
will.
there is not
I will.
necessary?
I will do that. I'm taking the wire first to a lady. Okay, then pull back.
No wall.
2 mm balloon.
Yeah. Absolutely.
Well, the other thing which helps, but obviously you've got two trapped wires, is to do a ports now, and your cells.
Fielder FC.
Give me a fielder FC, please. Sometimes the fielder wires with the coating helps the wire.
So you modified the tip somewhere, or what you did?
Yes, I took another wire.
Another wire.
It's a fielder.
Fielder.
It's a filter wire.
Fielder.
When post then we may go up with a non-compliant balloon.
Negative.
Table plot. Which is the balloon which you took?
It's a 212 mosaic.
212.
Mosaic.
We have taken a 212 mosaic compliant.
Put the wire out.
So the
And
question
now
is,
what I'm going to do is, no,
at what point would you think removing your trapped wires?
now the circumflex, because one dilate that.
And you have the second trap wire in intermediate, so I understand.
Yes, we have. See, once I open the struts,
And the way your trapped wire is not.
yeah. We had a reasonably good resistance pulling the one trapped wire. Talker. Filter. Okay.
What balloon did you use for opening the struts? 2.5 millimeter diameter?
Mosaic 2.5.
2.5. Maybe it's not.
Okay. Yeah. If I can get more easier. Small test. This is the old wire, right?
This is the old wire. Old circumflex wire.
Old
BM
circumflex wire. And new circumflex wire.
This one.
Okay. I'll try. The fielder wire back.
You are going to use a Fielder XT, Fielder FC wire for rewiring the intermediate branch.
I am trying that because anyway
Helio
there is two wires there.
Helio coil.
Small.
Yeah.
There it goes. Epicorn.
Excellent.
Thank you.
Okay, so fielders.
So now I will take the Ramus old wire out. Okay. The
So now you have a very
balloon
good
in the-
starting position for further interventions because all of the arteries are rewired.
correct. You know. அது முடிச்சோன்னா
So the next step will be to open the ostial of the diagonal branch with balloon
wire.
or the
This
cutting
wire.
balloon.
Diagonal or intermediate?
Intermediate.
And now I won't use a cutting balloon again.
Yeah, for the intermediate branch.
Yeah. Now what I'm going to do is I'll try if a stent crosses without difficulty what pressure we went up to.
14.
This is the Ramus, right?
This is the Ramus.
Give me that a 3 NC balloon.
You crush on the Ramus.
Yeah, I'll do the 3 NC short balloon. I will open the struts properly.
And what's your plan? How to? What are your thoughts about dealing with this, sir? What
Okay,
strategy will you take?
what my plan is going to be now, I'll dilate the circosteum well and get a 3 millimeter stent there
What
across the Ramus.
T
It's a tap. It's a tap. And deploy those two properly. And finally, I'll get go across the stud into the Ramus and do a kissing there.
Let's stand from here. This part is a little.
So now you have
There's some disease there. We'll take a picture. Do we have a short stent? Any 8 millimeter?
Yes. Sir.
Okay,
3/8.
go up. We'll use because distally it is disease. I don't need a very long stent there. Negative. Yeah. 3 into 8 stent and 5 millimeter balloon.
IVUS,
because
what was the size of your prox circumflex on IVUS?
main was 5. 5.
You'll trap the filter.
So now once we do this, we have only one tapped wire, that is the tapped wire in the ramus. That would be the last to come out, and we'll try and fix that too.
You don't want to open again the osteum of the ramus branch before putting the stent in the circumflex. You are supposed to do that first, no?
Ramus I didn't dilate because I have already used a cutting balloon and prepared the lead.
We missed okay. And with what?
I'm going to the circ
With stent?
with the stent
5 millimeter balloon.
and a 5 millimeter balloon in the LED.
Okay. And it is 3.0 stent?
This is a 3.0 short stent. Technically, it will be a challenge to position that.
Yes.
But I have some distal disease in a circumflex. I have to manage that.
Samuel, to precisely place the stent in a bifurcation lesion like that, we are currently using the stent boost or equivalent clear stent from Siemens. I'm sure that you have the system in your lab. Are you using it?
Phillips have got a, yes, we will be doing it. Here. Make it smaller.
So tap is a minimal protrusion of the stent in circumflex into the left main and immediate crossing.
Stent boost looks quite good.
It's okay.
Okay.
You can do that.
Again a stent boost. We are deploying the, because being a short stent, it's a very major challenge.
It's on 8.
Negative. I'll come back a little, deploy it properly. Okay. Okay. Deploying the other stent, negative. This here I can wire only in the circumflex. Okay.
This Remus is not bad.
Ramus doesn't look bad, but okay, a picture. What our plan, Ramus plus shift left main. So I would be able to get another stent into the ramus, and we should be done
Do
with
you
that.
think, Samuel, that the ostium of this remus was not covered by the stent you implanted?
It is covered.
So
What
you
is
need
it?
to rewire again the intermediate branch.
That's correct.
I mean, going back to the initial drug-eluting balloon suggestion, and we have had a fair bit of experience in these situations, and often you have a positive
Once again,
drug-eluting
this
balloon rather
was
than a
the
conventional balloon.
Circ.
339 circ.
Okay, okay.
That is the remus.
Okay,
Remus.
give me that Sion wire again. Ajit, hold both. I think then things would be much
Samuel,
more.
what about the heparin treatment? Are you checking the ACT?
We have I think
6.5.
units of heparin per kilogram body weight.
Okay.
Usually it lasts, in our experience, lasts quite well, at least for 2 hours.
Yeah. Give me an ACT anyway.
Anyway, now that you have asked, we will not deny you that figure. We'll give it to you now. Please. Put that wire into the LED, coming back, pulling back into the left main. It fell into the circumflex ostium, and here
Same maneuver you did for rewire.
Wire? Are you using a Zion wire?
yes. Yeah, it's a Sion wire.
So when you do these cases, which is
Yes.
elective, and this is for the panel, what dose of heparin do you give? Is there a standard dose? Do you give it per body weight?
Yeah, 100 micrograms per kilogram body weight.
Is that
100
what you do
units,
here as
sorry.
well?
Sorry?
Do you do it 100 units per
Yeah.
kilogram? Using it for any elective cases?
Yeah. 100 per kilogram. It is our first dose, standard dose, and then we rather not check.
The usual dose we are using for regular PCI is at the half, 15 units per kilograms. We are using half of those if necessary.
How it is in France with bivalirudin? You use it or
No,
not?
not at all. We
And
start.
STEMIs, but after the heat.
In Poland it is dead
Yeah,
because
for us.
of these results of the HIT PCI in primary PCI, and it is also much more expensive, so we don't use it at all.
Using 50 for a single vessel elective PCI with no problems at all.
You talk about the unfractionated heparin.
Unfractionated heparin, yeah.
I do have a technical challenge that ostium is really
now,
tight.
Now it is very tricky because you have a second stent, so
Give me a Fielder XT.
Yes, you have to cross the struts of the stent, so it's much more difficult.
Absolutely.
Maybe you can use again a
Okay.
field more rigid,
Yeah, we are
and
using.
smaller and smaller.
Thank you for the comment.
It's maybe better to and Samuel S. is on aspirin and clopidogrel.
Brilliant. Ticagrelor.
Ticagrelor. Interventions.
Like this, we would prefer, because the non-responders in the clopidogrel group is significant.
In your center, Jacques, you reserved this new antiplatelet for
Yes.
ACS only?
Yes, yes, definitely yes.
And in UK?
Yeah, I mean, there is no evidence that new antiplatelets is any better than clopidogrel in elective cases. So
Thrombosis and clopidogrel
Yeah.
systematically.
It is very important message to transmit that if you have a
Come to
stent
epicardial.
thrombosis, so it is maybe better to switch to ticagrelor or prasugrel.
And we prefer prasugrel.
We got the wire in.
Stronger medication.
Yeah.
yeah, in a way that shows the difference of
Are
quality
they-
of the different wires. How the way this
Elio?
wire handled the bend compared to the sine wire.
Go, Leo. The one disadvantage with this wire is the visibility is very poor.
Yeah. Great.
Okay, we are in business.
Yeah, yeah.
2 millimeter balloon.
Okay.
1.5 balloon.
1.5 balloon. Okay,
We're
show
going
me
to
the.
do kissing inflation, circumflex, and ramus.
Because I cannot afford to lose this.
Sir, filter.
Okay, I'll get a. Once I do that, I would to, and then I would have the second guiding coming in through the left groin.
Samuel, if after ballooning of this ostial lesion in intermediate artery, you will have an acceptable or not?
I will think about a stent, or I will have to use I'll have to use a drug-eluting balloon. I don't know who suggested advisors.
So you can
This one.
even this small balloon,
Which is the
these
second
stent
one?
struts in
You will remove the second filter.
Second
One.
okay.
Too many wires confuses. Okay, go up. Epicaudal, I want to get this wire down a little more. 2.5 millimeter balloon.
Wait, no, 2.5.
2.5 millimeter balloon, and and give me the 3 millimeter balloon back. I want to keep it in the circ. Bad. It's quite good. I mean, we have a real difficult, complex situation to get into the ramus. Still, the balloon crossed without any difficulty.
So now you will take just the regular balloon.
Mosaic and give a long. I cannot make out.
Are you going to do a kissing balloon
Try that.
inflation? 3 millimeter in the circ,
Yes.
and 2.5 in the circ. As you know, maybe you know that in France the rate of kissing inflation at the end of bifurcation is decreasing a lot. So we are maybe changing our faces, and we are now more and more using only the pot technique. So we open the struts, we are dilating the secondary branch, and we are finishing with a pot technique without any.
I mean, I read a couple of articles of from France. I mean, it makes absolute sense.
3. Huh? Neither in.
Yeah, now it's not very convincing result.
This is an NC balloon, no?
Well, from your Nordic studies, it showed that whether you kiss or you don't kiss, in terms of real life outcomes, there's no difference. The only difference is binary restenosis, but that's an angiographic finding rather than a clinical finding. So.
Recorder. More or less.
Yeah. 3, 9.
9. Go up, Ajit.
Other thing to remember is every time you kiss, you cause approximal deformations. You'll deport again at the end of it. So potentially you deport a part of the circumflex tendon, then port the left main again at the end.
Yeah, I see that now the time of the angioplasty for a very complex lesion is almost like the time for surgery.
Yeah. We ourselves are asking for it.
And more complex coronary artery disease because we treat more and more old patients. I think it's the same in France.
Yeah.
Okay. I remember 15 years ago or 20 years ago, primary angioplasty was done in the patients in the 50s. Now there are 70s, 80s, 90s.
Our oldest is
Go up
101.
on that.
So.
छोड़ दीजिए. I'll just pull the balloon back a little. Okay. What our plan is, the ramus looks great. We will give a balloon there, which is all going to be anyway. Before Sanjay, of course, the excellent chairpersons, Adam, and of course, we have been working for more than 20 years together.
Okay, congratulations.
Whatever you want. What shall we do? We should put a stand and
It'll deform them.
So, okay, now we have two presentations, and mine will be followed by Jacques' presentation, and I would like to introduce myself. I'm Adam Witkowski. I'm interventional cardiologist working at the Institute of Cardiology in Warsaw, and thank you again to Meril for inviting me here for this excellent course, and I would like to just share with you some consideration on the current update of left main stenting. These are my disclosure. I would like to base my presentation also on the ESC guidelines on myocardial revascularization. I had a honor and privilege to be in this group of people in this task force. These new guidelines were issued, like you know, 2 years ago, so maybe they are not so new, but there are no other. So, first, recent evidence suggests that PCI provide at least equivalent results to surgery for lower severity left main lesion at up to 5 years of follow-up. And I would like just briefly review with you some randomized trials, some large meta-analyses, and some large registries of left main PCI, comparing PCI in randomized or non-randomized fashion with surgery for left main. You can see here the indications for revascularization, and like you see, left main disease is the indication for revascularization of left main stenosis is not only for symptoms improvement but also for prognosis. So it does mean to avoid major adverse cardiovascular events, including death. The syntax score is important for multi-vessel coronary artery disease and left main disease because it was found that it is an independent predictor of major adverse cardiovascular events in patients undergoing PCI for left main disease. And it is probably the most important trial we have also for left main, the syntax trial, and you can see the results up to 5 years of follow-up, and it is very clearly shown on this cartoon that with low syntax score up to 22 and with the intermediate syntax score up to 32, the results of surgery and results of PCI are very equivalent, and only in a really high syntax score subgroups. So it does mean that it was not only the left main disease but also the disease in other parts of coronary tree. The results of surgery are significantly better in comparison to PCI. So now you see also the second very important randomized trial comparing the use of sirolimus elating stents with CABG for left main disease with 2-year outcomes, 600 patients randomized to surgery or PCI. Difference was in ischemia-driven syntax combat. It was a Polish initiated trial, and you can see again that in relation to death or myocardial infarction in follow-up, it was not difference between surgery and PCI. There is the main compare registry from Korea with a large population of patients, over 2,000 of patients who underwent surgery or PCI, but it was not a randomized comparison. But it is important because the population of the patient is really huge, and you have 5 years outcome, and again it replicates what we know from syntax or pre-combat, that there is no difference in the mortality or the major adverse cardiovascular events between surgery and PCI, but there is still a significant difference for ischemia-driven target lesion revascularization in favor of surgery. The main compare, you can see also that there were 2 waves of patients. In the first wave, the use, and in the second wave, only the drug-elating stents were used. And you can see that in this group of patients, the first wave of patients where bare metal stents were used, you can see also the difference in mortality. It is borderline, but in favor of surgery. However, when they change entirely for the use of DES, you can see that there is no any difference in mortality, and the only difference is still in target lesion revascularization. There is an interesting study again from Korea. It is not randomized, it is a registry, but over 800 of patients who underwent PCI or CABG for left main disease, and again you see that the only difference was in target lesion. If used in simple left main stenosis, there is even no difference in target lesion revascularization, but if it was the complex lesion with complex stenting, there is a significantly higher rate of target lesion revascularization in PCI arm. So this is the largest meta-analysis, 5 observational studies with over 3 years of follow-up, which included over 7,000 of patients who underwent surgery or PCI for left main disease, and you can again see that these results are the continuation what we know from the other studies. There is no difference in MI or stroke, but there is still a benefit for this comparison to PCI. Study again from Korea. The left main is the specialization in South Korea, and This is the pre-combat 2. It was not a randomized study. It was just the contemporary stents and cipher stenosis with the historical cohort who underwent surgery for left main stenosis in pre-combat randomized study. And again, if you look at the
primary endpoint of
adverse
major
cardiovascular events,
adverse
is
cardiovascular
composition
events,
of death, myocardial
composition
infarction,
of
stroke, or
cardiac
ischemic
infarction, stroke, or ischemic target lesion revascularization. There is no significant difference between PCI.
If you look at the single composition like death or stroke, again there is no difference in surgery. By the way, here is a very, very low stroke rate for surgery, which was probably unexpected by the investigators. But if you look for the driven target lesion revascularization, you can see again that there is in favor of surgery. So less patient underwent second procedure after CABG than after PCI. So if we look for a stable angina recommendation from the European Society of Cardiology, this trial, which were published between 2010 and 2014, really changed much, because like you see in 2010 the higher level of recommendation was 2AB for stenting of left main. Now for a simple left main lesion with syntax score of less than 22, you have 1B for surgery, but also 1B for PCI. For syntax score of intermediate value between 23 and 32, you can do left main PCI. There is 2A, so you should consider it, and only in the highest syntax score tercile, more than 32, the PCI for left main stenosis is not recommended. It is that the patient per definition for surgery. However, we know that in real life surgeons sometimes refuse to operate this patient because of advanced age or many comorbidities, and again this patient are in PCI arm. So what about the diagnostic technique? The FFR in left main lesion, in intermediate left main lesion, you can do. However, it is tricky because you have the inflow from the both arms, from the LAD and from the incautious, but the IVUS is first down left main and to guide the intervention lesion at least after the stenting, to know if the stent is full approach with the artery wall. And also the training and the competence, there are first time in the recommendations of the European Society of Cardiology, and it is clearly said that left main intervention, especially the distal left main, should be done by a very experienced interventional cardiologist. Some words and by 60% of cases which involve circumflex or at least the one branch, and in this kind of lesion, like you have seen at this excellent live case with Dr. Matthew, the lesion left main stent, long-term results. So you have seen on this slide many techniques which can be used for left main bifurcation lesion stenting. I will not go in detail through it, but only one And you have to remember about very simple, very simple, which was presented by Kang, again from South Korean group, that if you would like to avoid restenosis in complex left main lesion stenting, you should do an IVUS and know that the minimal luminal area in circumference, not less than 5 square millimeters, in LAD not less than 6, at the bifurcation not less than 7, and in the left main body not less than 8 square millimeters. It does not, of course, totally prevent the possibility of restenosis in left main, but it is just the rule to avoid the excessive percentage of restenosis if in left main. You always should consider to send patients to surgery, and if you decide to do a second PCI, you should do an IVUS to better understand the mechanism of restenotic lesion in left main, because if it is the stent under expansion, so it does mean that maybe just simple balloon redilatation of but if after IVUS you know that the primary reason for left main restenosis is just the excessive proliferation of no intima, it is better to use a second. So what in what about the dedicated bifurcation DES? There are no sufficient data for left main stenosis, and I think that there is rather not that these devices are not very frequently used. The very attractive hypothesis is to use the biodegradable scaffolds in left main lesions. However, we do not have data at all on it, and we have 2 trials, which first one, the Excel trial with everolimus stent versus surgery in left main disease. The recruitment is finished, and now we wait for the follow-up results, and the Syntax 2 with a synergy, which this is a stent which released everolimus from the biodegradable polymer versus cabbage, and it is not randomized trials. Again, it will be the comparison with the historic cabbage cohort from the Syntax 1, and we still wait for the results. So to summarize my presentation, I would like to say that since 2010 all published data on left main revascularization have shown very consistent that the hard endpoints like mortality and myocardial infarction and stroke hazard is comparable between PCI and cabbage, that there are 2 major differences between PCI and cabbage for left main disease. First, the stroke in majority of these trials is more frequent after cabbage than after PCI, and the target lesion revascularization is still more frequent after PCI than after cabbage, and especially for distal left main disease. In ostial and shaft left main lesion, PCI should be preferred because there is no difference even in TVR between surgery and PCI, and left main lesions and Syntax score from 0 to 32, PCI or cabbage decision making after hard team discussion. I think it is the best option, at least for patient with stable angina, and of course in patient with left main lesion, which is a culprit lesion for ACS, the PCI is a preferred approach. Thank you so much. So now I'd like to, yes?
Question, what is your rate now of surgery and for left main, for distal left main? Because, you know, for proximal and ostial left main, there is no more indication for surgery, you know, but for distal lesions.
I think that in my center still majority of patients, I do not remember the very detailed data, but I think that 60% are going for surgery and 40% are done by interventionalists.
We are doing 80% angioplasty and 20% surgery, you know, most of the time, because
our surgery are more stronger than yours, I think.
That's because we have not the surgical department in the same institution,
okay.
But it is just across the street, you know. But we also are working very close with them because we have participated in the syntax trial, Excel trial, and the last ideal trial also. So we are expecting to have the result from the Excel trial maybe at the next EuroPCR, because they are pushing a lot to get all the informations. Maybe we have some more information though at the EuroPCR.
If you have surgery on site, the life is not so easy.
Yeah.
Because we always have our surgical colleagues in cath lab and they are looking on the diagnostic angios, and there is an immediate hard team, and it is hardly to discuss if patient is, let's say, 60-year-old with left main stenosis and other lesion located in other vessels and with a syntax score of 30 or 32. So you can expect that this patient in our center are primarily for surgery. However, distal left syntax score, or in a patient who are in advanced age or have so many comorbidities that surgeon refuse to operate.
Thank you. Thank you.
Okay. Thank you so much, and now I would like to invite Jacques for his presentation on the Meril stents, I believe, yes?
Actually, 27 years ago when I came for the meeting, part of the Indian meeting. We trained lots of Indian physicians when I was in the hospital, so we have lots of connection with your colleague, and I can measure how important and how fast is the development of this country, specifically in cardiology and specifically with the companies that we are invited with. So this is my talk, is to start presenting the new Bioman stents that maybe you have also the experience with. This is my disclosure. So we know that there is a great enhancement in the quality of the coronary stents, which also makes that we are moving more and more to invasive cardiology as opposed to surgery in most of the patients now. Every part of the stent is very important. The platform, the metallic cobalt chromium new of the struts, the design of the stent. The second part, which is very important for a stent, is the polymer which is now more and more biodegradable polymers. The next generation of the stent have polymer which is degraded in 4 to 3 months according to the stents that you are using. And we hope, and we have some data to prove that this improvement in the quality of the stent and the polymer will translate in improvement in the clinical trial and the results for the outcomes of the patients. As you can see here in this slide, the first generation of the coronary stent was relatively bulky. The Cypher stent had closed cell, 140 micrometer strut thickness. And now the third generation, which is a biomatrix, which is also a very relatively old platform because the Strat and it's decreased to 65 micrometer for the strut thickness. Even more important, the polymer at the left, the polymer was not biodegradable polymer for the cipher and the taxus, and now this is a very high degradable polymer for the next generation, which is for the sirolimus drug for the. I think that maybe all the limus have the same quality in terms of decreasing the restenosis rate. And the next generation of the bioman will be the Havermine 50, which means that they are decreasing the stress down to 50 micrometer, which will be supposed to increase the deliverability and the conformability of the stent. So what were the important features of this stent? This is the unique stent viability that ensure less than 3% of the force-tuning, recoil and force-tuning, which is one of the problems that we have with the next generation of stents, specifically with maybe the Synergy stent or Promise stent from Boston, but also you can see this force-tuning for every kind of stent. What is also important is that the stent is mounted on a flexible PTCA balloon catheter with short, abrupt balloon shoulders, which transform the inflation technique of the stent as opposed to the regular stent. And we have a demonstration of that. As you can see on the right side, you have an inflated balloon in this very strange lesion in Lima, but you have a bone effect, the distal and proximal part, and then opening in the middle, as opposed to the Bioman stent, which expands from the center part and then finished by the proximal and distal part. I believe that this is a very important feature to decrease the risk of dissection. You can also open the struts very well when you need to do a bifurcation. The drug is a sirolimus drug. It is very well known, but 75% of the drug is released in 15 days, which is a regular way for this drug. I think one of the very interesting feature of the stent, is the biodegradable PLA stent now that we are using. And this is a very thin 2 micrometer only, and it doesn't crack when you have an inflation of the stent. The uniformity in stent coating is very important also for the long term. So this is a summary of the quality of the stent. Just briefly, one or two cases, that we are dealing with. It will be a very short presentation because next time we will have a presentation on the using of Bioman stent, long Bioman stent in coronary occlusion. This is a totally occluded artery, and after this pre-dilatation, you can see how long is the lesion and how nasty is the lesion with lots of thrombotic material inside and ateroma. So we decided to tackle this material against the wall of the artery by using a long Bioman 3.5 40 millimeter stent, and you can see on the right on the clear stent evaluation the excellent conformability of the stent. Of the stent, we could tackle all this material. I just want to show you another case, which is totally artery, and as usual, after opening the artery, lesions. So we used two biomine stent, one 2.5 37 millimeter, and the second one is the proximal part and the mid part of the coronary artery. And as you can see here, we can visualize perfectly the overlap of the two stents with only 1 or 2 millimeter of overlapping the stent. I think that because of the decrease of the struts, stent is not a concern for the future of the patient. I don't think that we will see an increased rate of restenosis on these overlapping lesions. And you can see the perfect results, the perfect artery. Unfortunately, it doesn't work for everything, and it doesn't work, for every lesion. This is a shepherd curve right coronary artery, which was relatively difficult with calcified lesions at the mid part of the artery. And unfortunately, despite multiple injections, we could not place a biomine stent or a Corofix Blue Neo, which is for us the best stent capability for crossing now. So hopefully, but we have the technique of the guiding Godzilla catheter, and it was very easy after on the Godzilla catheter to get the final result with a biomine 3.590 millimeters. So the clinical program of the biomine is now underway. We have seen published, sorry, doesn't work, okay. We have already seen, okay. We had Merit 1 and Merit 2 studies, which was the primary, in the first-in-man patient for Merit 1. We have now Merit 3 and Merit 4. More than 6,000 people have been, patients have been enrolled in the clinical trial. Most of the time, these studies have been conducted by our Indian colleagues from Hyderabad, Ahmedabad, or Delhi. Merit 3 was a clinical 30 to 40%, which is very important, and much more important than in Europe. And as you can see on this slide, Merit 1 and Merit 2, the primary endpoint was an angiographic endpoint, and you can see that the late loss in 0.811, 0.11 for the second one, which is really excellent. And for the third study, which is Merit 3, with at 1 year follow-up for 1,000 patients, you have only 2% MACE. And I will present next the next station the French cohort of absorbed people, and you can see that we don't have with the absorbed people, we don't have this kind of results. This to convince everybody we need a randomized study.
We are in the process.
This is a prospective open label study in Europe and Brazil. With angiographic control. We
just 5 minutes.
Are expecting the results in the next year. In conclusion, they have been, in my mind and in my experience, biomine Meril carries all the characteristics of a modern coronary stent, a modern third generation coronary stent. Very thin struts, rapidly biodegradable stressing polymer, highly effective antiproliferative, low late loss, and excellent follow-up results. And in our experience, and I think we will see in the next presentation, the longest platform are easily deliverable and very effective.
मुझे 1.5 का 1.2 का balloon दे दो. We have gone to that side branch, sir, दिख रहा है? So 1.
Is a regular access with a stent, like the next generation of the stent. You can open very well the
sprinter का भी ready रखना.
As usual, the problem, in bifurcation, and we have a special fixed session, that is, you need to cross the distal cell in order to get the best results for angioplasty. And it's not very easy.
We're in the side plan.
In most of the This is the main problem is.
Should we take second wire now?
नहीं sir, पहले रास्ता बना लें. Then we take it.
Sometimes you take the cell, you can take
Yeah,
and
yeah,
not distal one, because it is sometimes impossible and you leave your time and the time of the patient and much radiation and you can...
This is what,
I must,
1.25?
I must tell you that you can do,
1.25?
which is very important, is a 7
15
French
SLA.
guiding catheter.
Name
You
of the
can do
balloon?
cases
Mosaic.
stenting without two stents
Mosaic,
in the
MO.
same- the same guiding
it's true.
catheter.
Catheter should be a routine for left main distal stenting. I think that with a 6 French you can be in trouble sometimes. So, any questions from the audience to Jacques? If not, so thank you very much again, Jacques, for this
Thank you.
interesting review. And now we have a 15-minute break. Yes. 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 I think that
I'm going up, sir.
That's the case.
For all
We
the
just
आगे जा रहे हैं.
already.
yeah, the case is ready, so maybe we will continue with the case. So I would like to ask Dr. Józef Jotkowski here,
अब सब पीछे कर लीजिए सर.
and our other expert, Dr. Ramesh De Silva from UK, and Dr.
एक बार और दे दो.
Pier Francesco
whisper दे दो.
from the Netherlands.
Okay, okay.
Yeah. Everyone is here.
Yes sir. Picture लेते हैं सर. Yes sir.
Very nice. अब तो
विस्पर दे दो मेरे को एक. आप सर केस डिस्कस करो, मैं विस्पर उसको डाल देता हूँ मेन.
So I don't know if the class lab is ready. Can we connect?
Yes, we're ready. Can you hear me?
So it is Dr. Upendra Kaur, yes?
Yes.
Hello. Do you
Hello.
hear us? We can see you.
Yes, very well. Can you hear us?
Okay.
Yeah, yeah. ये निकाल दो जरा.
We hear
हटा दो
you
ना.
very well. We see you.
काट दो.
We are here in
Very
Warsaw,
good. So I'm showing you my
in
full
the
face now. ये हटा
Meril
दो ना.
Academy. And my name is Adam Witkowski. I am from Warsaw, and the coaches and the experts are Dr. Józef Jotkowski, as well from Warsaw, Poland, Dr. Ramesh De Silva from UK, and Dr. Pier Francesco Agostino from Netherlands. So welcome, and please say us something about the case
Good.
you prepare for us.
So we are here from New Delhi, Fortis Hospital. On my right is Dr. Ripin Gupta, my trusted colleague, and on the right of him is Miss Smita Wilson, who is our cath lab nurse. She is a very well trained nurse, and in fact, when we do procedures, she is the only person who is assisting. But today, since it's a we have a very capable technicians team led by Mr. Shashi Bhushan Mishra and Uday Singh. So now I'll go to the case. Can I have the first slide, if you have? Yes. This is a 48-year-old gentleman. Interestingly, has no major risk factors. And he presented with a history of classical angina in ending Feb this year, and had some minor ECG changes, and he was put on dual antiplatelet therapy and then referred to us for an angiogram. Dr. Ripin, can you show the angio? We'll show you the angiogram. Hello, can you hear us?
Yeah, yes, we can hear you. Thank you.
Okay, good. Can you see this right anterior oblique view?
Yeah, we see the right oblique view for the left coronary system, and we see the chronic total occlusion or something like
And
this. I understand it is not
yeah,
ACS
there's
patient. Is correct? Yes.
that's we can see lesion in the second part, which looks 50 to 70%. So this is the angiographic picture. Basically triple vessel disease, but the right coronary lesion which looks intermediate, left anterior descending lesion with, I think most of us will say that it is significant, and obviously the real terms which is very tight.
ACT.
First, next is to do a FFR of the right coronary lesion, and the FFR of this at maximum hyperemia, and indicating that this is not a ischemia producing lesion. Next. No. इसके बाद है ना?
Can I?
LED का किया था।
Do you have evidence of
Yes.
ischemia in the lateral territory, or are you using a normal echo as a
A
surrogate?
patient has a absolutely normal echo, no wall motion abnormality, ejection fraction about 65%.
So, Petra,
So after doing the FFR of the right, yes,
your strategy is to do FFR in the right coronary as the first attempt, and if FFR will be
that's right.
positive, let's say, so you will have a patient, a young patient with triple vessel disease, so you will go for PCI or for surgery?
I think in this situation, I think even if we have very rigorous criteria of appropriateness, LED is a mid-segment lesion. Right, in case it is a significant lesion, is a very big vessel, easily doable with angioplasty, and then circumflex with our experience 3. So from all criteria, I think angioplasty is a good solution for this. Although, you know, CABG can always be done. He is not a diabetic, so from that angle also,
Yeah, it's true.
I think angioplasty for his age, a young person, anybody would prefer angioplasty, and especially when we are in a group
So,
of
Upendra,
interventional
if the
cardiologists, I
angioplasty
think,
is-
yes.
Upendra, if the angioplasty is decided already, should you start from the circumflex as the most difficult part of your procedure or not?
Yes, that's a good question. Actually, what we did, which we had not captured on the screen, we also did a FFR of the LED. And it was significant, it was coming as 0.72. So now we are in the process of
So
LED. Yeah, 0.75.
this is LED 0.75, RCA was 0.88. Okay.
Yeah, well, was one issue that is the collateralization to the circumflex, and I didn't properly see how the collateral is coming, but it's possible that the LED
Yeah, there
is
are-
collateral to the circ. So you can
actually,
over-evaluate the FFR. So what would be nice is to open the circuit and repeat the FFR in the LED
Collaterals coming from
and see whether it becomes
actually, the right coronary artery, if we see carefully, is giving collateral. If you see
There are
this
also
frame,
collateral from the
the
right,
right
yes.
coronary artery is giving the collaterals.
So the
You can
majority
see
of the
that.
collaterals coming from the left in any case.
No,
No, they're not.
no.
As you can
If you
see,
go to the caudal
this is
view,
the
actually from the
anti-gate.
diagonal probably. You have a huge collateralization to the
But
circuit.
I
no,
think
no,
collaterals from the LED.
No. We can do an FFR, no in harm in that.
so one can argue out whether to do LED first or the LCX first, but we thought that let us handle the most complex region first, and we went ahead, took a Fielder XT wire. This is how you see is moving slowly, and it has gone finally into a tiny branch which is adjacent to the large obtuse marginal. So at this stage we thought, let us make a better passage, and we dilated it with a 1.5 millimeter from Meril. And this is the dilatation, and now you can see the picture, and we have kept the wire there. This is where we are now.
Did you cross using a fine cross microcatheter, the second wire?
No. What we did is the Fielder XT went into that small branch which is adjacent to the obtuse marginal. We'll show you again. We just left it there and took a whisper wire. You can see it here. So you can see the main vessel, and this is in a very tiny branch. We dilated it to make a passage. Took this second wire, XT wire, and this whisper XT has gone into the appropriate vessel, and the other wire has been pulled out. So this is the picture, and this is where we are now. So now we dilate it with bigger balloons.
Yes, sir, 2 है, sir.
Okay. Now we're going with a 2 millimeter balloon.
2.5 ready balloon.
We're going serially so that we don't produce a major
2.0 balloon, and
Why is it
then
fine?
take a long stent to cover the entire lesion.
Yes, then we'll see, we'll take a long stent, we'll see whether we need a tapering stent or we need a usual stent.
Why did you choose a whisper as opposed to say something with a better shaft support, like a balanced heavyweight, if you're using a long stent?
Because we wanted torqueability.
I thought we were very comfortable with the torqueability of the whisper, and there are, is a tortuous kind of a lesion, and but I'm sure any other wire would also have gone. Once the passage was there, we could see it. The balloon, as you know, is melon seeding.
Take a longer दे दो थोड़ा.
यहाँ करो.
Yes.
How long is this balloon? 15?
12.
This is 12 millimeters.
20. We're going to take a longer balloon.
I think we'll take a longer, but just
20
write it here.
20 दे दो, 2.5 20. 2.5 20 दे देते हैं.
We'll take a longer balloon because this balloon has a tendency of melon seeding. It either goes distally or proximally at the tight portion. And we don't want injury to the adjacent portions of the vessel needing a much longer stent. Okay, let's take a picture.
Nikoran.
Hmm?
Nikoran.
Yeah, let's take a longer balloon. And I think this might be good for a tapering stent. 3.53.
Yeah, 60.
Take a long balloon.
20 हो ना? Any comments? Comments from the audience? Audience comment.
Hello. Can we also participate in your discussion?
Why do you need do you think that you need another balloon instead of going straight forward with a stent right now?
We have to.
Because we're taking another balloon because we have not been able to expand the balloon fully because it's melon seeding. It's either slipping distally or proximally. So that portion is not opened well. So
And it's a bigger
the
size.
stent would not be fully expanded. So let us make a proper bed. And in these days, when the days of BVS, we are tuned to making a bed very well. Unfortunately, we can't use a BVS from Meril today because the study is over and we're waiting for the 6-month results.
Push.
Okay.
Are you working with a 6
So we're
French
taking a longer
guiding
balloon.
or is it a 7 French?
This is a 6 French. 6 French.
Normal 6, okay.
6 French is,
Con-
yes, his
CLS
radial artery was
or,
rather small. Yeah, this is
backup,
a XB.
XB, okay.
Yeah, extra backup.
Yes, sir.
So this is what length?
20.
20, so we'll need at least 40.
40. Maybe 50. I will just take a picture, sir. Would have an idea.
Now,
One of
is
the interests
15,
to use to predilate the lesion is, as you can see, the lesion is increasing a lot. So when you want to select the stent, you need to have enough flow to the distal part. And with this predilatation, you can make a more appropriate evaluation of the diameter of the artery and the diameter of the stent. And the positioning also of the stent. So predilatation has some interest in some circumstances.
3 balloon.
This is the same for myocardial infarction.
To expand.
okay. Let's take.
There is a relatively small marginal
Take a
branch
picture.
coming out at the level of the occlusion. Would you consider protecting it or not really? It's not that big, but it's
not
also
really.
not that small.
Yeah, but that point, the proximal point, the point where the vessel was totally occluded, happy with its expansion. So we're using another balloon to dilate it. We use a 3.5 millimeter balloon to dilate it.
3, sir.
3 millimeter balloon to dilate that.
And are you using a non-compliant or a semi-compliant?
We'll use a semi-compliant. No, this.
Sir, comments on regular or morph? Comments on regular.
Now the other point is whether we should use the conventional stent, which is uniform in diameter throughout its length, or is this a case where we can consider using a tapering stent, morph, the biomime morph. Because we have this availability of a variety of choices. with the biomime stents. And at the end of it, after doing the angioplasty and putting in a stent, we also
Yes, sir.
take it
Yes.
slowly. So this is the 3 millimeter balloon, and this has expanded quite well. Now we'll just get an idea about the length. So the proximal end is okay, and distal I think
40,
we
3.5, 340 morph.
So we'll take a 3.5 morph, that means proximally it is 3.5 and distally it will be 3.
Cutting too fine.
40 we think will be absolutely okay. The 20? 23, okay, still better.
I think it was a 30 balloon.
OCT कैसे रख लेना? OCT. Yes. No, this was 23.
323.
3 into 23.
23
Yes. Meanwhile, keep your OCT catheter exposed proximally and distally.
Nominal कितना nominal?
So here comes the stent, and let us see the trackability. Trackability is nice.
Pull a bit, sir. Yes. Pull a bit.
Did you take the
Yes.
biomime morph? That's a question from the audience.
Yes, yes, this is biomime morph.
Push a bit, sir. Push a bit.
I think we need to push it a little bit, push the wire a little bit first.
Yes. And then
So it's
extend a little bit.
biomime morph,
No, the wire.
40,
Okay.
3.5 at the
3.5.
proximal edge and 3.0
थोड़ा
at
सा
the
पुश
distal
करना है,
edge.
थोड़ा
Yes,
सा
it's
बस।
correct.
अभी नीचे आ रहा है, but अगर थोड़ा सा पुश करें।
Yeah, this is biomime morph 3.5. That means 3.5 proximally and tapering to 3.
Yes, sir.
I think both the markers are well set, and we're inflating it, and biomime morph is being inflated.
9 is a nominal.
9 is the nominal. Okay. That should be enough. ऊपर 3.5 का ले लेते हैं. We'll see the picture and then do an.
For OCT or?
Yeah, that's what we're debating. Most probably it would need a
3.5
dilatation.
and see.
We'll take a non-compliant 3.5, maybe 9 or 10 millimeters.
वैसे लंबा देना।
Picture. Yeah, looks a good result. So proximally, I think we'll do with 3.5 and then do a
15.
then do an OCT. Yeah.
So angiographic
Balloon.
results is perfect, Upendra, but I understand you want to post-dilate and then to do OCT.
I think
just
we,
to know.
yeah, that's expand as portion.
ये मैं करता हूँ, वो रेडी करो OCT.
So we're taking a 3.5 millimeter balloon, mean
This more long morph to the stand.
we went up to 12 atmospheres.
12.
Okay. Being a 40 millimeter stent, it tracked very well
Una whisper wire.
in spite of all the curves, and so we are in the stent. Okay, this is the portion which a little less. And now we're going to high pressure,
14,
going
16.
to 14, 16 pressure. Okay, that's all.
A bit more distally, so low.
Little bit here also. Okay.
12.
And balloon? Is that correct?
Yes, it was 3.5 non-compliant balloon, 15 millimeters length. We're taking a final picture before doing the OCT. Looks great. Let's do the OCT now. Which, as you know, is a very small monorail catheter. थोड़ा आगे. It's about to come. Okay.
Can we
Okay,
see
ready?
OCT panel on the screen, please?
Yes, now we're going to inject. Yeah.
कंट्रास्ट दे दो ना, इसी में से करना है.
हाँ, इससे कर लो, इसमें
We
निकाल
don't
लो.
need
हाँ, थोड़ा निकाल
FFR.
ये निकाल लो,
हाँ करते हैं.
ये डाई निकाल लो, ये ब्लड निकाल लो.
How do you perform the OCT, with manual injection or with the automatic injector usually?
No, manual injection.
You
Okay.
consider
Okay.
removing the wire?
No.
No, it's a pity.
Okay.
Get much better pictures.
ब्लड आ गया.
Some blood has gone in. We'll do dye, full dye.
फुल टाइम है सर.
Okay. Okay. इतना ही किया इंजेक्ट
जा ही नहीं रहा सर उससे यार
यहाँ से कर ले इंजेक्ट
गाड़ी पर और
I think that you proved your point. The stent is well opposed.
इससे
उससे
Are you
क्या
still
होगा
going to do the LID later on?
Yes, yes, we're going to do LED immediately after this. I think this is better.
I think this was probably your best run.
Of contrast.
Okay. Yeah, the stent is very well opposed from distal to proximal end. Okay. Want to do one more? Just one more attempt to see the proximal end here. Judge. Okay.
better.
Yeah, this is well opposed. You can just stop it here. So it looks very well opposed. So we're taking out the OCT cap, take a picture and go to the LED.
विदाउट वायर से वायर फिल करके
क्या है
विदाउट वायर फिल
हाँ
Will you repeat the FFR on the LED?
No, we'll do the LED now, and then if we think that it's necessary to repeat, because we already done the FFR on LED. So this looks quite good.
We can do an FFR also, sir, on LED. If they
Yeah,
want
we
to.
can. You want us to do FFR again on LED?
It may have changed.
Later on also. दिखाओ.
Let's do the
FFR wire.
FFR wire. पड़ी है ना wire? You don't need calibration? Do the calibration.
Pressures कम आ रहे हैं.
Sorry.
The St. Jude wire or the volcano? And how do you give adenosine? You give it via peripheral infusion, central infusion, or bolus? Intracoronary bolus?
In this particular case, we very often give it
ट्यूब में डालना है.
infusion when there is a long lesion. The intravenous bolus has the same correlationship. हो गया?
एक सेकंड. डिस्कशन कर लीजिए सर, मैं तब तक रेडी करता हूँ.
So, what do you recommend? The intravenous or the intracoronary? Infusion or the bolus?
Sorry? And I prefer.
I was
much
just
more the
saying,
infusion.
what does the
Definitely. Personally,
Infusion,
I prefer
yeah.
infusion. I don't know what
Yeah.
the other of the panel do, but I always do infusion, but I do peripheral infusion. So in the arm, we try to puncture
Yeah.
a bit higher in
And
the
like
arm,
water.
at the level of the elbow, and we give the adenosine there. Also because I always like to do the pullback to be sure that you get
Yeah.
one in the guiding cut.
The
as
point.
a quality control
That's right.
for the value.
So we're advancing the FFR wire.
Well, one alternative is to use for long lesions. You can
Go on, sir. Aerocranial.
select
Aerocranial.
the best place where you have to put the stent.
वो करना पड़ेगा.
Okay, equalize.
एक सेकंड.
Okay. So equalization done. इंजेक्ट कहाँ पर है? FFR. Oh.
Okay, can we switch to FFR screen now, please?
Yeah.
Sure, sure.
Can you switch to the FFR screen?
We have something in between of camera and FFR. Okay, thank you. Now it is removed.
Can you?
Now I think we see
Oxygen
that
लगा
there
दो
is a
पहले.
significant
Oxygen लगा दो.
lesion, so you can stop.
So I think
Can you
what's
do a
it?
pullback?
0.78?
Just to see.
0.68.
It's 0.68.
the quality
0.68
in
and
the
we'll do.
guiding.
Yeah. We'll do a. So that should be proximal to the lesion. Lesion, so which needs to be handled. Is
हाँ ऐसे भी कर सकते हैं.
just a test.
2.5 का balloon दे दो.
So we.
This side.
It has to be little positioned.
Any comments?
So the collaterals had not affected the flow.
2.5 का. नहीं हैं? 2.
But that was an important point. I think we appreciate the point. देखें?
Yes. Oh, close.
बंद है.
Just to pull it and keep it in the distance.
हाँ कर देंगे.
एक सेकंड.
इसको हटाओ ना. बड़ी चुकी है सारी.
Yes, sir.
0.5 balloon.
Picture लेते हैं.
Yes.
इसे pressure display करो.
Actually, the lesion looks quite significant angiographically also now. Yeah. La. Is going to require a relatively long stent. Maybe the proximal end and the distal end of the
Considering direct stenting? Or you prefer to
no, we're pre-dilating it. Yes, yes.
थ्री का बलून दे देना लंबा
Okay.
आगे से चलते हैं सर
This is length is
12 sir 12 12
2.5.
12
So this is 2.512.
we go up sir. down go from yes sir. Beyond this sir we have to
Okay. Right.
Are you considering a morph stent in this region too, or you think about a non-tapered stent?
yes
Okay.
$60 चाहिए होगा इसमें 60 मॉर्फ लेते हैं
क्या कह रहे हो
60 मॉर्फ 3 2.5 करके ऐसे
I think we'll take a morph stent here also. Three 60.
yeah 360 should be okay because we have a lot of
Long.
space.
Yeah, so we are going to take a 360
360
by my
regular
morph.
stand, I understand. Yes, Upendra. Just a regular stand
Yes.
or a morph or a taper stand.
Morph, tapered, morph.
स्टैंड दिखाओ स्टैंड मॉर्फ
It's
मॉर्फ
a pretty long lesion. नहीं है
3.5 ले लेते हैं सर अच्छा
Okay,
रहेगा
right.
दो 3.5 60 है दो
Okay.
हाँ 3.5 60 है दो
Now let's take a 3.5 because the distal vessel is so we take a 3.560 and see how does it track on the FFR wire. A test for Meril.
जस्ट पोस्ट हॉस्टल रखेंगे
We'll just keep it post-osteal because there was some disease there also.
So how long is your stand?
6-0.
6-0. 3.5 to 3?
That's right.
गाइडिंग चला जाएगा फिर डिलीट करना पड़ेगा वी हैव टू डिलीट इट वी हैव टू डिलीट इट
Yeah, yeah. Show the guiding, show the guiding, show the guiding. We'll have to pre-dilate it.
Are you working on the FFR wire, Is it correct?
Yes, that's right. Yes.
So the wire is not there.
Okay, little support wire. Keeping this there only.
The other option is you could use a
BMW
guideline or a guidezilla.
Hello, caudal.
Because FFR wire actually is not so good and so supporting. You know, it has a lumen inside.
Gently.
Okay, let's go to other view. Good.
Huh? 3
All star from Abbott.
All star.
You can take out the other wire.
You had some balloon trauma at the site of the pre-build.
पिक्चर लेते हैं सर दे दो फिर सेक्शन होगा कोई वहाँ पे फ्लैप में जा रहा होगा हाँ डिसेक्शन है वहाँ पे फिर जेंटली जाना पड़ेगा
I
वायर नहीं
think
पुल करनी
you had a dissection in the proximal vessel.
give him
You might be in that.
या एक मिनट इसको ना वो करना पड़ेगा इसको नहीं विल टेक मेरे को वो दे दो मिश्रा जी और वो दे दो एक वो कैथेटर दो प्रोग्रेड दो प्रोग्रेड दो वो वाला फाइन अपने वो है ना क्रॉस हेयर हाँ we take a micro catheter.
I think we can take a micro catheter on the.
नहीं ऐसे नहीं करेगा नक्कल ना बनाइए सर नहीं डिसेक्शन बढ़ेगी सर yeah looks gone let's check let's go let's check and see sir
Let's check and see. I think we have gone.
एक मिनट सर डाई चेंज कर रहे हैं
हेपरिन दे दो और थोड़ा
या
वो दे
आई विल पुल आउट द अदर वायर
तो इसमें से ये है ना
हाँ यस सर यस
we pulled out the
You should probably switch with a fine cross or a microcatheter, I think.
no we already let us see now it's crossed we'll show you so it's crossed now we'll dilate it take a good balloon 3mm balloon
3 का दो मेरे को
Do you consider a non-compliant balloon to pre-dilate now, or would you go for a compliant?
We can go with a non-compliant.
ये दे दो yeah let it park here sir let it park here it will cause dissection let it be in the main sir it will be
no ठीक है आगे मुड़ी हुई है तो छोटी सी ब्रांच में लाओ
Can we see another view, perhaps, just to almost an eleo-cranial view?
Yes, we will show you. Okay, make a eleo-cranial. Okay.
Oh, yeah, the true human.
Yeah.
Go back to the
previous view. Okay, so that's fine. Yeah, that's the place. Okay. Okay. अब वायर को ठीक कर लें
So,
आगे?
so this is a non-compliant balloon?
ये parked है वो. Yeah.
Yes, this was a non-compliant balloon.
And you went how
So now
how
we'll
high
take a picture.
in terms of pressure? You
We went up to 12.
Oh, 12. 12 to 14.
12, 14.
Okay.
So now we'll take a picture and try the same stent again. Yeah. So
No stent.
I think it should go now.
It's looking happier now.
Otherwise we'll yes, much happier. We're also looking happier. So now and let's see whether to go.
Guideliner दे दो.
So we need a guideliner.
Let's go in. Yes, sir.
थोड़ा push चली जाए शायद.
Which curve of the XABCAP do you have? 3.5?
3.5.
3.5.
No, I think we need a guideliner.
गाइडलाइनर दे दो. गाइडलाइनर दे दो तो नहीं जाएगा ना मिश्रा जी.
नया ना?
Yes, sir.
ठीक. चलो.
So the second option is to use a
So we
body
take a
wire.
guideliner.
Sometimes it's helpful.
Yes, but I thought, you know.
Let me hold the bag.
Yeah,
Okay.
with guideliner you should succeed. Because
Yeah, so using a guideliner.
it's much more better support.
इसको सिर्फ लूज कर दें.
कहाँ अटक रहा है ये?
चलेगा सर. एक मिनट. Let me do it.
Okay. Should be coming now. Okay. Should be all there.
हाँ बस बहुत है सर.
I think that should be enough. So that's the
Now
trick
it
of the
is-
guideliner. So
Now it is done.
So guideliner showed us the way.
Full, sir.
Let's go to iliocaudal.
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 You can go to ostium, sir, because you can go up to the ostium because.
Pull लेते हैं.
Pull कर लेते हैं.
Should be maybe more
It's a very
proximal,
good angle, so we come up to the ostium.
just to cover the,
Yeah,
the
this looks
ostium,
okay.
because then you will have
Yeah,
restriction.
so this should be all right.
Little bit, sir. Little
थोड़ा
bit.
सा पीछे?
थोड़ा pull करना है, sir. Yes, sir. Yes, sir. I think this should be fine.
That should be fine. Go ahead. Okay, how much?
9 nominal.
9 is a nominal, so 10. Okay.
Guiding, right?
Do you find that
Oh,
with
yeah.
these long stents, when you take the balloon out, it sucks the guide in a lot more? You said that your guide got sucked in.
Yeah, that's right. Always. Yeah. Okay, let's go to the cranial.
Looks nice.
Looks nice.
You
Like
want
to do an OCT?
post-dilate with NC? You want
Yeah,
to
with the
post-dilate
post-dilate,
with NC balloon?
3.5.
We will first we'll do a post dilatation
3.5.
with 3.5 and then an OCT and
दो 3.5 दो.
ये हटा लो.
ये रहने की से जरूरत पड़ेगी अगर शायद बलून में.
चलो. लाओ बलून.
न्यूयॉर्क देना. ऑक्सफोर्ड नहीं. दो.
बलून.
एनसी. एनसी का डब्बा मिश्रा जी उधर डब्बे पड़े हैं एनसी के. हाँ 3.5 में दिखाओ क्या है.
कोई सा ला दो यार, वहाँ से ला दो.
उधर भी पड़े हुए थे ना एक
Get
सामने.
it from the other stock.
हाँ इसमें है ना. ये एनसी है ना 3.58. हाँ दे दो. एक ये भी एनसी देखो क्या है ये. इनका देखो.
Dr. Cole?
हाँ दो ना 13 दो.
Yes.
The problem with this very long stents that we cannot know when we will going to stop the double antiplatelet therapy. So what will be your strategy for the patient? How long will you give him antiplatelet therapy?
I think 1 year for definite.
Yeah.
And in case the DAP score is low, that means the risk of bleeding is not high, then we'll continue for maybe 2-3 years, or maybe just one more potent agent like
Just stop. After 1 year.
yeah, for 1 year definitely 2.
Yeah,
And
we have
following
data
1
on
year,
it that there is
depending
less,
upon the
major adverse cardiovascular events at the cost of some more bleedings.
आगे सर आगे
This is
सर.
what
Yes.
was expected.
That's right. This patient is already, because of his recent ACS and other things, on aspirin and ticagrelor. Okay. Come to iliocaudal.
So what is the pressure you use? 16, 18 or what?
14.
14, 15.
14.
14, 15.
14, 15.
Now we're
So it
coming
is
to the
not very
Austrian.
high. We usually expand with non-compliant balloon up to 20, even more.
Yeah.
Sometimes.
Gone to high pressure now.
Now with here we went up to 18.
You see also sound classification exactly where I put in the balloon there. There is sound classification
Yes.
just outside the
That-
stand. That's probably
that's
the reason why
right,
the stand didn't pass. Because this Austria classification.
That's I think that was the reason, yes.
Pull, sir. Austin. Double Mac.
Do a double Mac.
Double Mac stand boost.
Yeah, we're inside. Okay. Maybe we can do a stent boost now. Okay.
फ्लोरो सर
Fluoro, yeah.
छोड़ दीजिए सर हाँ हो गया सर we are in the edge.
It looks
we are
well.
just at the edge. We are just at the edge.
Can you,
We'll
can
do
you
it,
show us the stand boost?
12.
Can you show them the stent boost?
Because that doesn't come in our screen.
Yes, yes.
Done.
We'll show.
Done, sir.
दिखाओ stent boost दिखाओ उनको.
So we want to finish with
Can you bring it to the main
second
screen?
OCT run, yes, within this artery.
Yes. Get the OCT catheter.
How
Guideline
much
out.
contrast has this patient had?
250.
Around 240, 250. His creatinine clearance is normal. He is not a diabetic. He is well hydrated. Should tolerate it. Okay, take a picture.
Guiding in करना. अभी नहीं होने से बहुत कैट हो गया.
Huh. Can you see the stent boost now?
So Upendra, we are waiting for this OCT because we are over time.
Yes, yes, yes.
So please show
No
us
problem. We
this
just
as soon as
OCT
possible, and we
OCT
have
catheter is
switched
going
to
in.
the conference room for two last presentation of this session.
Yeah, the OCT catheter is going in. आगे ले आओ. वो कैलिब्रेशन वगैरह कर लिया है इसने? दूसरा व्यू करो. आगे
आ रहे हो?
आ रहे हो. So that is the OCT catheter beyond the stent. Blood, full of blood.
पहले कर लीजिए सर. मैं बस इससे पुल कर लीजिए सर. पुल लिटिल बिट.
वो तो कर लूँगा लेकिन अब ब्लड निकाल.
वो मैं निकाल दूँगा. पहले मैं पुश करके निकालना पड़ेगा. आप करिए. इसको भी खोलिएगा सर. इधर से ब्लड निकल जाएगा. बस बंद कर लीजिए सर.
ओके. उसको कर लिया पर्ज.
और
पर्ज. ओके. ओके. वो बताएगा.
रेडी.
ओके. ओके.
इसमें नहीं वो नहीं है.
नहीं नहीं बाहर है वो.
इसको
Just will take a minute.
The comment
Just
from panel
clearing
is
the
that
blood.
maybe you are too proximal because we see a stent in this. So maybe
Yes,
you
yes.
should go deeper
No, we thought
with
all
your
the dye
OCD.
should go in.
Ready?
Yes, just a minute. Pull kar raha hu usko main.
Yes, sir.
That should be just okay. ठीक है?
गाइडिंग ठीक
नहीं
है।
गाइडिंग बाहर है, अंदर ही करना पड़ेगा।
हाँ गाइडिंग अंदर रखिए सर। हाँ थोड़ा और सर करिए। हाँ यस अब ठीक लग रहा है।
चलो सर टेस्ट दो।
यस सर।
ओके।
नहीं थोड़ा
फिर बाहर आ जाते हैं शॉर्ट लेफ्ट में।
पुल कर लीजिए ना सर, पुल गाइड कैसे को पुल कर लीजिए इसको ना, इसको सर ओसीटी को, ओसीटी को,
ओसीटी को।
यस अब ठीक है। रेडी?
So we'll see the picture now.
Well opposed.
Yeah, well opposed. I don't know whether you can see it. Completely opposed. Yeah, that's out in left main.
No, stop. Now we're in the left main. Now we're left main.
Yeah.
1 or 2 struts in the left main. Oh,
okay. Have you seen it?
Review the proximal part because there are some. We are not sure. If
okay, just go to the proximal part. We can see that 1 or 2 struts are in the left main.
Yeah, it is. But it is at the entrance to the left main, so you cannot do anything with this. So I think that result is excellent. So congratulations, Upendra and your team for this excellent case.
Thank you very much. Thank you very much for being with us.
And
have a very nice stay in Vapi.
Have a good to see FFR. So thank you very much, and very good results with these long stands. Thank you so much.
Just the last picture. There's the last picture.
Heliocaudal.
Heliocaudal. Let's go to heliocaudal for the
fantastic results.
Double में घटा दो.
Just center, please. Yes.
Great. Thank you
New
again.
arteries.
And we
Okay.
switch now to the lectures. So maybe have some more lights because I can not read anything.
Challenge.
Remaining lectures and only one? Dr. Pier Francesco Agostini, who is an Italian working in the Netherlands. So stand you observed in Upendra Kaul case in long diffuse chronic total occlusion. Pier Francesco.
Thank you very much for the invitation. I would like to thank Meril for inviting me and for having me here, and I would like to share with you a little bit my experience with the biomorph in CTOs. We had a beautiful case of from New Delhi just now, and my presentation goes more or less in the same direction. What is called the hybrid approach. That means that according to several parameters that are listed here, you can choose the way you will approach the CTO. You have basically 2 ways. One is antegrade and one is retrograde. And then you have 2 ways to cross the lumen, and can be true-to-true crossing or dissection re-entry techniques. The combination of these 2 approaches and these 2 ways of crossing the CTO makes let's say a scheme like this one, where you have antegrade wiring, antegrade dissection reentry, retrograde true lumen wiring, and retrograde dissection reentry. And the combination of all these four techniques is what is called the hybrid. And what is nice of the hybrid is that you can switch from one to the other. If one doesn't work, you can, in the same session, go for a second technique and so on. And this approach, the hybrid approach, leads, in experienced hands, up to a success that is about 90, in some cases even more than 90%. So CTOs are almost coming close to normal PCI in terms of success. One issue of CTO, and we saw just now a case in New Delhi, is that sometimes you have, of course, you have the CTO lesion that can be short, but you have a diffuse disease of the vessel before and after the CTO itself. So most of the time in CTO you end up with long stents because of this diffuse disease. So it's not only the CTO that counts. The previous case was very teaching in this direction. There was a relatively short CTO lesion, or very short CTO lesion, but very long diffuse disease vessel. Currently, we performed recently this big registry that is called Research, about more than 1,200 CTO, prospective included, treated by hybrid operators in Europe. We had a success rate per procedure that was 86%. At the level of the patient, including the re-CTO procedures, we reached 89%, so pretty good result. And what is interesting is that the average stent length was 72 millimeters per CTO. So very long stents were needed, or multiple stents and overlapping stents. And here is the number of stents used, 2.4 on average per lesion. Again, pretty much. So about 70% of the cases in this registry needed more than 50 millimeter stent to treat properly the CTO. So in this setting, I think that this stent, the Biomime Morph, because of its length, is a potentially very good tool to tackle this lesion, because you can minimize the amount of stents that you use. You can, if you can bring this stent in, you fix the problem in one go, and this is very interesting. And plus, there is also the tapering feature. So you have a stent that is half millimeter larger in the proximal part and half millimeter smaller in the distal part. And that makes also the procedure safer, because you are less afraid of having issues at the distal landing zone in terms of edge dissection. So I will show you some cases that I performed recently in my center. I had the chance to use the device from, I think, February, March. So I had a few cases that I performed. I start with a relatively easy CTO. We see an occlusion here of the right with a very, let's say, visible microchannel, so it's almost a macro channel, I would call it. It was taken with just antegrade approach, one guiding, no retrograde injection, because I thought it was not needed. Support of a microcatheter, easy passage of a XTR wire, pre-dilatation, and you see that at this level the balloon doesn't expand, probably a calcified plaque. With pre-dilatation, with the non-compliant, then it was possible to have a reasonable result. And then this lesion, pretty long. CTO is, again, is relatively short, but this segment is diffusely diseased, was tackled with one Biomime that starts here and ends there. This is a Biomime 3.5 3060. You see in different views, positioned just at the level of the crux, inflated. You can see a bit the tapering from distal to proximal, sorry, from proximal to distal. And then a second stent proximal. As I don't have the normal Biomime, I decided to use OR0 because it has the same drug. So proximal stent 22, so in total about 80 millimeter stent for the final result. The second case of antegrade wire escalation, a bit more complex, mainly because of the anatomy. We see a right that is somewhere on this, at this level closed, with a huge collateral network, and very difficult to identify the path of the vessel. Here, with the steel frame, I did it a bit like this, so runs at this level. But it was very difficult to identify the cap. Actually, by testing the wire, testing the lesion with a wire, if you see the wire in place, then it becomes much more clear where the CTO is. It's just there. It's a very short lesion, not calcified, no bend, so it's very easy CTO afterwards when you understand the anatomy. This was easily crossable with a Gaia second wire and microcatheter support, pre-dilatation, and then positioning of the first Biomime stent from the ostium up to after the CTO, 302.5, 60, inflated, and again you see nicely the tapering of the balloon. Good result of the stent, but again distally diffuse the disease segment of the right up to the crux. So I decided to try for a second biomime stent, morph, and I put a 302.5, 50, and this I don't have the image of the stent in place, but this crossed easily, and I put it in the direction of the RDP. Then I recrossed, and this was also easy, in the direction of the posterolateral branch, post-dilate the stent with multiple post-dilation with a 3O non-compliant balloon, and this is the final result. That looks pretty good. Of course, this is a full metal jacket. You have 11 millimeters of stent from the ostium out to the crux, but I think it was needed to treat this vessel properly. So we go to a little bit more complex techniques now. We have, again, a CTO with abrupt occlusion at this level with blunt stamp, so difficult to take in an antegrade way. I think it was already attempted before, so it was already a failure. There is also a bend at this level, 45 degrees bend. So here we start going up in terms of JCTO score. We have a retrograde visualization from the left coronary artery that is pretty good. And we have also pretty good collaterals. Here I made a still frame of the collaterals from the circ. This vessel is very attractive for retrograde. And actually it was very easy to pass with a turnpike microcatheter for retrograde approach. So this is an epicardial collateral in the AV groove, but it's very straight, very big, so it's very attractive. You bring the microcatheter just at the level of the CTO distally, and then was a relatively easy passage of the wire. So again, true lumen approach with the Gaia second wire. This passed quite easily, turnpike behind, you make the loop, and then you can further proceed in pre-dilating the whole lesion and then put in the stent. Problem of this lesion is that it was ending again at the level of the bifurcation. So in the end, you needed to stent just over the bifurcation. So what I did is to remove the turnpike just after the bifurcation in the posterolateral, bring a second wire antegrade, and on this wire bring a biomime morph 60 millimeter, park it just after the bifurcation, and inflated it. And then I put a second stent proximal to finish the work, because again it was diseased. It's again an O030, proximally located up to the left main. Again, it was easy passage at the level of the bifurcation in the direction of a posterolateral and post-dilation of the whole statin segment with a non-compliant balloon, and this is the final result. So we go progressively to more complex CTO sceneries. This is another case of retrograde. We have a proximal occlusion of the right with a long segment, long occluded segment, and an exit bifurcation that is very unfavorable for antegrade approach. So we decided also in this case to tackle the lesion through a retrograde approach. However, the setup was done also to use crossbows and antegrade re-entry technique in case of retrograde failure. So this is an 8 French femoral antegrade catheter to be used in case of antegrade section re-entry techniques. But the collaterals were pretty good retrograde, and indeed it was possible to pass again through AV groove collaterals from the circumflex. Here is the reverse card technique. What you do is you go subintimal with the antegrade wire, you go subintimal with the retrograde wire, and then you balloon the antegrade space to try to bring the wire back to the intimal space from retrograde to antegrade. And this succeeded. So it was possible to make the loop, and then on the wire of the loop, so it's a very solid system, you can bring relatively easily down the morph, again as a 60 millimeter morph, from the ostium up to the distal right, inflated, again you see the tapering, and this is the final result after the morph, and looks pretty good. And one more, and this is the last case I want to show. One more technique is the antegrade dissection re-entry technique. We see here a pretty complex occlusion of the ostial LAD at this level. There is substantially a blunt stump, in my opinion. There is maybe a very small, tiny something that comes there, but it's almost a blunt stump. So I call it a blunt stump. We can discuss about that. There is for sure a bend, because the entry of the CTO is a 90-degree bend. It's long. It's more than 20 millimeters long. There is a lot of calcium. It's also post-bypass patient, so it makes it even more complex. Actually, the reason to open this LED was to tackle this diagonal branch that was unreachable through the lima, because it would go lima, LED, back to the diagonal. And the patient had ischemia in this region, a lot of pain, so there was a strong indication to try to tackle this. And the only way to tackle this, in my opinion at least, was to open the LED in the direction of the diagonal. And there were substantially not clear retrograde possibilities in this patient, because you wouldn't go through the lima. I mean, you could try, but you have a major risk to have major issues. So we decided to tackle this by antegrade approach. Again, it's an 8 French guiding catheter here. So prepare to use all the antegrade dissection reentry techniques. And actually, the wire went in the good direction, but it went subintimal. Once the wire was subintimal, we used this device. That is a crossboss. I don't know how many of you are familiar with this. This is substantially a device that tends to remain into the architecture of the vessel. So you push it, you turn it very quickly. It has a tip that is a bit rounded, and it doesn't perforate. It's very interesting because it goes through. Sometimes it goes from true lumen to true lumen, like in this case. Most of the time it goes subintimal, but it remains into the architecture of the vessel. So it passes the CTO, stays in the subintima after the CTO, and it parks itself just in the subintima after. You see here what happened. You see that the device is exactly at the level of the middle AD, at the level of the septal, outside of the vessel, but still in the architecture of the vessel. At this point, what you do, you switch for the second part of the whole package of the antegrade dissection reentry technique, is the Stingray balloon. So you bring this balloon, that is a special balloon. Actually, there are 2 balloons together. Looks like, as the name says, Stingray, you know, the kind of fish. And this device has 2 markers and 2 holes. According to the position of the device, you have 2 holes, one that goes, let's say, up and one that goes down. So you can choose to go left or right according to the position of the device. I show you here. So here you see the device is parked outside the vessel. You see a bit of contrast in the device. You see the 2 markers, and you know that in this situation you have to go with your wire down. If you go up, you would perforate outside the vessel. If you go down, you can re-entry. And then you have a special wire that allows you to make the re-entry, and that's the case here. You see this, you puncture the subintimal space, and you puncture the intima, you make the re-entry with the wire. Once you make this, then you know that you are again in the true lumen, so you can go further. You bring the wire down, and then becomes a standard procedure. In this case, because of the extreme tortuosity of the vessel calcification, it was very difficult to bring the biomime morph inside, so in the end I had to do aggressive predilatation. I had to bring a guide liner, a bit like the case we saw before, and with the guide liner in place it was possible to bring a 60 millimeter morph inside the vessel, park it after the lesion in the diagonal, that was the target, inflate it, and then after a second stent into the left main that was also diseased, this is the final result. So in conclusion, CTO are frequently associated with a diffuse disease of the coronary vessel, leading to the use of long stents or multiple stents to fix the problems. The biomime morph, in my opinion, appears a very interesting adjunction to the armamentarium we have in the cath lab to fill the gap of the relatively short stents, mainly in this situation. In this preliminary series, I've used morph in the cases that I showed, and then I've done a couple of extra cases. It always succeeded up to now, so it looks like compatible with all the hybrid techniques for CTO. And I think a randomized trial to prove the additional value of this stent in CTO would be definitely very, very much welcome. Thank you very much for your attention.
Thank you so much, Pier Francesco. There are any questions from the audience about the CTO? Do you think that for long CTO or lesion bioresorbable scaffold technology may be the future?
I think that the major limitation of the bioabsorbable is the fact that it can be very tricky to bring it down. So, well, if you can implant it, it's interesting. But to bring it down, it's in these anatomies can be very,
yeah,
very,
for
very
technical
tricky.
reasons, but
yeah,
I
just
mean
purely for technical
because
reasons.
there are very long lengths of the artery usually to be covered by the stent, so it is why I think that bioabsorbable technology may be the future, of course, if the technical problem would be overcome.
Yeah.
Jacques?
Yes, but the problem is we don't know what will be the resorption of the biovascular scaffold when you are sub-intimal, where you're not in the true lumen, we are outside of the lumen. And with the hybrid technique, you are outside of the lumen in many circumstances. So we don't know. Maybe it will be very helpful, but we don't know, and we don't know if the resorption will be the same.
One thing that is very important in the antegrade dissection re-entry is that originally there was the STAR technique, the one that Colombo developed, and the re-entry was very, very uncontrolled. And most of the cases, they ended up stenting the whole subintima. And then if you go all the way to the end and you stent the subintima, it looks like you are again in the true lumen, but you are not. And this vessel, they close after 1 hour. With these devices, like the crossbow stimulator, you have a controlled and sure re-entry. You are sure that you are again into the true lumen. And then if you make a connection, true, false, true, this, in my opinion, and I've seen cases, stays open very frequently. So using conventional stents. So the chance of restenosis is I would say, as a feeling, not more than normal CCIs.
This stent thrombosis is more frequent?
Not in my experience, honestly. No.
Thank you. That was a good presentation. When you say you're true, false, true, has anyone looked at what happens to stent coverage in the false bit? Because the physiology there is different, isn't it? Because you're in the adventitia and you're not actually in the intima or the media. You're outside of all of
You're a
cells.
bit in between.
Yeah.
I know. On the other hand, you think also the CTO is such a diffuse disease process that I think what happens there is a mixture of everything, you know. It's very difficult in the CTO segment to really define what is what, because you have like so much disease that all is kind of mixed and spread up. But I don't have an answer to your question because I personally have never done like serial OCTs, and I don't know if someone did it. But for sure, I mean, hybrid techniques are, let's say, existing in the last 4 or 5 years, so it's definitely something that we need to investigate properly.
There is a microphone.
What is your experience with dealing with all those very long morph stents? You end up with a stent in the artery or sometimes outside the, subintimal, whatever. But my question is different. What about side branches that you need to save sometimes, or you want to reopen? How does it go with the morph stent?
Yeah, I've shown a couple of cases where the recrossing was very easy. Like the distal right, I had 2 cases where
it was easy,
there was
actually. In your experience, the side branches are not a problem.
Yeah, no.
Recrossing it is not a problem.
Of course, if you stand subintimal and there is like a vessel there, then
different.
you lose it. And
no, but once you're in the lumen, recrossing the stent is not impeding on you recrossing the lumen.
No.
Okay.
I think that the thinnest of the struts, the thin struts are very effective for recrossing because the struts are very thin, so they don't impede the flow through for the diagonal branch, the secondary branch, and so it is much more easy, I think, for with thin stent to cross the branches, to cross over the branches,
Okay, this is very interesting discussion, but if there is no more questions, so thank you, Pier Francesco, again for your excellent review and excellent cases. And I think, Zach, that we should to conclude. It was the last morning session, and I understand that now is a lunch, but we need some advice from the Meril people where this lunch is. It is here or it is outside? In the clubhouse. So there's transportation provided. Okay. So thank you for your attendance. Thank you, Jacques, for co-chairing this. Sir, all of the expert and the audience, and we will reconvene after lunch. Thank you so much.
1 minute. दो मिनट में दोनों में डाल के दो कहाँ से लिया था वो वही किसको रहा Hello, 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 mic check, hello, mic check, hello, 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 mic check, hello, mic check, hello, hello, mic check, hello, hello, mic check, hello. Hello, mic check, hello, mic check. Hello, mic check. Hello, mic check. Hello, 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 hello.
Hello. Good afternoon, doctors. We are going to start with an BRS session, that is bioreabsorbable scaffold session. I would request Dr. Berland from France to please come on the stage. And as far as the panel is concerned, I would request to come on the stage dais, Dr. Ramesh De Silva from UK, Dr. Anirban Chaudhary from UK, Dr. Jairam Aitel from UAE, and Dr. Mrs. from Poland.
Okay. Dear colleagues and dear member of the panel, I have the objective with this talk to teach how to start with the BVS or BRS. I don't want to speak about fancy indications, so this is a basic presentation. As you can see on this slide, we used to work with very bulky system in Rouen, so that means we had the opportunity, they asked us to run BVS. The rationale for BVS selection is very important. We have the scientific support of long-term results with the cohort A and B. But the first premise is we need for the patient significantly life expectancy to experience the resorption. We are working for the long term with the BVS. We are not working for 6 months. We are working for the long term. And also, we have to be sure that the patient is able to comply with double antiplatelet therapy. The duration of antiplatelet therapy is still a question with BVS. And the third part of this third premise is we need optimal BVS implantation. All the current prostheses or scaffolds are very bulky. We hope that in the future they will decrease the size and the thinness of the struts, but all the scaffolds are very bulky. We are coming back from the very thin struts to a very bulky system. We are coming back from the modern era to the first era of drug-eluting stent. It's as bulky as the Cypher. Four principles for implantation. You need a good support, radial or femoral. If radial, consider the Schisless 7 French system. You need a good lesion preparation, a good BRS implantation, and a final BRS assessment. Support, first, you can use extra backup curve for this indication, for this implantation. And if you can use a 7 French. You can accommodate from the radial, sorry, you can accommodate with the radial approach, you can accommodate a 7 French guiding by using the Schisless from Hasei, which is very effective. And also you can need guiding support like the Gitzilla or the Guideliner. So you have to have experience with this system. And you have to prepare the lesions, which is the most important fact. With properly sized balloon, the balloon that for pre-dilatation has to be the size of the balloon of the balloon of the BRS, 1-to-1 ratio. Most of the time we use a non-compliant balloon and rotablator for calcified lesions. And for this lesion preparation, you have to think about the role of intravascular imaging. Just want to present a case which is not a fancy case, it is a case in 25 years old female, very young patient. She, 3 months after delivery of preterm baby, they had an acute coronary syndrome with EKG signs of ischemia in the anterior wall. She had also a troponin positive assay. This is the coronary angiography of this patient, 25 years old. As you can see on the slide, there is a very severe mid-LAD stenosis. She is 25, she is not smoking, but she received corticotherapy for inflammatory disease. The strategy proposed was to perform a CT examination pre-dilatation because of the age of the patients, post-pregnant patient with suspected dissection or vessel hematoma as a reason of these lesions. And we want to know, we plan to do in this very young woman, we plan to perform BVS implantation, absorb implantation, followed by non-balloon post-dilatation according to CT results. The recommendations are there, you know, from the Netherlands on the right part of this slide. Patients, young patients with good life expectancy are the best indication. So this is a very young patient, so this is a very good indication for BVS, you know. This is the OCT examination. And as you can see on this OCT examination, we were extremely surprised at that age. You can see very well on the screen, you know. It's very dense atheromatic lesions. And not calcified, not severely calcified, but still atheromatous lesions. The area was very low, it's 1.25 millimeters square. So the area of the lesion, the minimum area of the lesion is very severe. And what is important with the use of intravascular imaging for BS, you can check where is the normal artery, and you can check the distal diameter and the proximal diameter of the artery. On the left, the distal diameter was 2.80 millimeter, and on the right, the proximal part of the artery mean diameter was 3.25. So we decided, according to the results, to implant a 3 millimeter BVS, 80 millimeter lens at 18 atmosphere. To check with the OCT, you have an incomplete expansion with an area of 505 millimeters square only, and an asymmetrical expansion, you know. So we post-dilated with a 3.25 millimeter, which was the rule in France. You have to increase by 0.25 the diameter of the post-dilatation balloon at 18 atmosphere. And as you can see, we did not get any improvement. Still 5.25 millimeters square. We use a 3.5 post-dilatation balloon. We had a slight improvement in the area, 6.29 millimeters square. And also with an angiographic correct result. So we decided to stop there. We don't, as you know, it's not possible to over-inflate to implant the prosthesis. And the patient came back 1 year later for a typical chest pain. And because this case was really interesting, we made a control angiographic. The angiographic control was satisfactory. And the OCT examination 1 year later is depicted on this slide. As you can see, this is on the upper part of the slide. This is the area that we have, the minimum diameter area that we have stented. And as you can see, the stent is well covered, well implanted in the wall of the artery. And we have some improvement, you know, slight improvement in the area. It was about 6.5 millimeters square as opposed to 6.2 after the implantation. So we have a slight improvement with the time in this patient. And that's what we are expecting for the regular implantation. We are expecting to have a slight improvement with the time. So for BRS implantation, progressive inflation up to 16 atmosphere, prolonged inflation, you know, to wait for 30 seconds to transfer the energy of the balloon through the prosthesis and through the artery. So you have to do prolonged inflation. And systematic non-compliant high-pressure balloon inflation, in our experience, 0.025 is not enough, 0.05 is necessary. And if necessary, and in about 20% of the case, you need feline intravascular assessment. Why do we need this? this is in a meta-analysis which will be going to be published in NeuroHeart, in European Heart, 2,568 patients in control studies have been recruited. And as you can see on the left part of the slide, the regression shows that when you increase the rate of IVUS or OCT examination, you significantly decrease the rate of subacute thrombosis. And on the right also, as if you more and more you are using post-dilatation, more you decrease the risk of subacute thrombosis. BS for long lesions, you have to see, you can see on this slide that you have base markers at the distal tip. If you want to do edge-to-edge positioning of two stents, you have to use this marker, and if necessary, stent enhancement visualization system is much more helpful. In the regular X-ray equipment and geographic equipment, you can see that. You cannot see that. For long lesions, as you can see also in this slide, as if you treat long lesions, you increase the risk of subacute thrombosis. It is a question when you are using long BVS for total occlusion segments, and also as a standard, for standard stents, you increase the risk of subacute thrombosis when you are using also with STEMI. In STEMI, this new prosthesis. Bifurcation lesion is not, for me, a perfect indication. Provisional crossover one scaffold is preferable. Two stents technique are very challenging, time and resource consuming. And in this indication, IVUS or OCT is mandatory. We had the opportunity to run the French Absorb registry in my institution with my colleague, Professor Dr. Koenig. So we started in September 2005 with a 5 years follow-up. It's sponsored by Abbott Vascular, but it has been, it is run by the French Interventional Working Group, GACI, for the French Society of Cardiology. This is a prospective, well-controlled registry. So in this population, why did we choose the BVS? 70% of the indication was young patients. In 16% was acute coronary syndromes. Potential bypass site, because we hope that when the prosthesis will disappear, it will be a potential lesion for bypass in the future. 9% diabetes and 9% lesion length. The recommendation for the selection were very strong, not to calcify, not excessive tortuosity, no left band, so very simple lesions, We need good pre-dilatation. Unfortunately, we ask for post-dilatation with a non-compliant 1.25 millimeter diameter larger than balloon, which is not, I think, a good idea. And we try to convince the groups to use OCT during the first implantations. So we had 2,277 lesions, and despite the rule, we had 0.5% of bypass, 12 patients, and we had also restenosis lesion in 1%, but mostly the lesions were totally in agreement with the recommendation, except we had 13 left main lesions. Bifurcation 8% and total CTO 8.3% occlusion. Pre-dilatation was performed in only, I think, only 94%. That means that in 6% of the procedure, people did direct stenting, which was not allowed to the protocol. And also post-dilatation was performed in only 73% of the case, which is much higher than all the registries that we have in the literature, but it's not perfect yet. The success rate of implantation was extremely high. What was the rate of complication? We had only the 1 month follow-up at that time. We had for 43, which is relatively high, I think so. three patients died, and 3 young patients died, unfortunately. 2 BVS thrombosis. 2 of these patients had direct stenting without predilatation of the lesions. Myocardial infarction was recorded in 18 patients, and total BVS stent thrombosis at 7 days was 0.8%. Between discharge to 1 month, we had 3 more deaths, 3 BVS thrombosis, 5 myocardial infarctions, 3 target vessel revascularization, and total 6 more stent thrombosis. That means at 1 month, we had 22 stent thrombosis, 1.08 patients. When you look at and you compare this registry to the other published registry, GHOST, which was the most important and the most, Gabihar, Ripara in Spain, I think so, and Absorb first, you can see we are in the range of this complication with definite and probable scaffold thrombosis around 1% at 30 days, which we have 1% at 30 days. GHOST, it was at 2% at 1 year. So we are in the range. This is the beginning of the experience in France. So this is not, you have very well trained groups doing lots of more than 100 implantations in this registry, and also few centers with only 1 or 2 or 5 implantations. Yeah. So the rules are very important. The 4 P's for optimal BRS implantation: prepare the lesions, properly size the vessel, pay attention to expand. Today, commercially available BS need a more meticulous implantation technique. We are going back to the first time of tertiary experience with relatively simple lesions. The assistance of intravascular imaging system is extremely helpful, and not only for complex lesion, but you have to start to understand what is a BAS. It's not a standard stent. You have to try to understand the mechanism of the BVS. Let's say a personal opinion, significant late clinical improvement compared to current BAS. The comparison has to be made with the new generation of TVS. For example, the Armand has to be demonstrated to overcome the increased procedural cost, which is, I tell you, not significant as you compare to standard PCI. Thank you for your attention.
Okay.
Thank you, Jack. Any questions at all? I can start with one. What is your opinion about how? Is there some literature saying you go from the external elastic lamina to the external elastic lamina? Some say you go from the lumen to the lumen. And clearly, like the case you showed us, if there's a lot of intimal hyperplasia, lumen to lumen.
We measure the area, the inside area, and not the big wall area. And that's why maybe we got suboptimal results because we thought that we had to.
यहाँ से कैमरामैन को बुलाना है, यहाँ खड़े रहना हुआ कोई आकर के गड़बड़ ना करे.
भाई, hello, भाई. That's why you also have to do. Hello, live हो रहा है यार, फोन आया.
What is your opinion about stenting vessels like 2.5? Because now it's believed they consist of like half of that thrombosis, please.
showed that for vessels below 2.5 millimeter, the risk is 4 times the risk of failure. So don't use it for small vessels. At that time, don't use it for small vessels. OCT is much more easy to deal with than IVUS, you know. We are not using, we are only using IVUS for when we need for the protocol, for example, for left-main protocol, because they ask us to, but we start using IVUS when we use OCT.
Thank you. So we want the next speaker.
ठीक ठीक
एक सेकंड सर माइक
हेलो हेलो
ऑडियो मिल रहा है सर
कैन यू हियर मी
Want to start?
Okay.
Start now.
Well, so good afternoon, friends, ladies and gentlemen. So I'm going to present in next 15 minutes MERES 1 study update and my experience with MERES 100. As you would know, that recently we have concluded the recruitment of MERES 100 trial patients of 108 patients. I don't have any financial disclosures to make. If we look at the ideal BRS characteristics, and that is what we are looking for, it should be novel scaffold architecture, it should have low strut thickness, low delivery profile, should have an high radial strength, high flexibility and deliverability, high good radio opacity, which is a big drawback of the BVS at the moment. Convenient side branch access should be there. There should be large size matrix. Conventional deployment method should work in the ideal BRS situation. There should be conventional storage conditions, so you should not be, like a conventional metallic DES. It should be stored in similar fashion. Adequate scaffold upgradation profile should be there. Compatibility degradation by the product should be there. So if you look at the currently available Absorb and the MERES 100 Absorb, the scaffold architecture as against the multi-link design platform of the Absorb from Abbott Vascular, the MERES 100 has got hybrid geometry, closed cell at the edges and the open cell at the mid-length. The strut thickness is significantly lower, 100 micron compared to the 150 of Absorb. The crossing profile is also significantly lower, 1.2 millimeter compared to 1.4 millimeter. And then there are 3 unique, radio opaque markers on each ends as compared to, pair of radio opaque markers in the Absorb stents. And size matrix is more flexible, 2.25 millimeter to 4.5 millimeter, and length also they have proposed from 8 millimeter to 40 millimeter as compared to the Absorb, which has got limited size from 2.5 to 3.5, and maximum length is 28 millimeter. And the biggest plus of MERES 100 is it can be kept at room temperature. The advancing BRS science to MERES 100, there is an alteration of design from earlier generation linked ground configuration to hybrid design geometry that is inspired by the BioMind family of drug-eluting stent design. And there is no compromise in is also not going to be compromised. The strut thickness has significantly come down to 100 micron without loss in radial strength, so that's again a big plus. Improved crimping profile from 1.5 to 1.2 millimeter, which makes it more trackable. And then change in triaxial radio opaque marker configuration from the circular disc to the couplet of double height. If you look at the architecture of again hybrid cell design, you can see that both ends are having the closed loop, and then it is again, PLLA 100 micron strut thickness, and in the middle there are, open cells. The scaffold architecture is a novel hybrid cell design comprising of an intelligent mix of closed cell at the edges, open cell along the length, ensuring optimal vessel wall conformability. And this design also allows for reduction of strut thickness without compromising the radial strength or the flexibility. And these are few pictures from the OCT. The low strut thickness, you can see from the comparison, these two pictures are showing, you can easily differentiate that the conventional absorb has got, much bigger squares on OCT compared to the 100 micron Meril squares, which are much smaller, and that is the advantage of this stent. A crimping profile also, it's significantly lower, 1.2 millimeter, so that ensures unhindered navigation through vessel tortuosity, and tight anatomical situations also it would be much more trackable. The radio opacity, as I said, it has got 3 radio opaque markers at the either end, and making it much more visible and convenient, and gives good estimate of scaffold expansion by simple eyeballing in 2 orthogonal angles prior to invasive imaging such as OCT or even the intravascular ultrasound. This is a running picture, and you can see in the left anterior descending artery, the scaffold is there. Are there, and the distance between the distal edge of balloon radio opaque marker to proximal edge of a scaffold is 1.3 millimeters. So balloon overhang for post dilatation would not be an issue, and that can easily be tackled for post dilatation as well. The side branch access for post dilatation capabilities, as I said, that it can be up to 26 atmosphere expansion can be done, and post dilatation can be, so if you look at the post dilatation parameters wise, maximum post dilatation 0.5 size can be upped with the principal mode of degradation is hydrolysis via mass loss, and byproducts are excreted as CO2 and H2O via Krebs cycle. So it does not web, cramp, lump or on the stent or the balloon surface. So that's again a big quality of this product. The drug release pharmacokinetics, the sirolimus is loaded up to 1.25 microgram per millimeter square of the total scaffold area, and the predictive cumulative drug release profile, you could see that its uniformity reaches within 60 to 90 days, and up to 120 days maximum thing is released. The degradation begins from a high molecular weight, and the entire scaffold is consumed over a period of 2 years, as against the loss in radial strength is also after significant amount of time. So acute loss of radial strength to the lesion is not a concern. If you look at the histology of the rabbit iliac arteries at 28 and 90 days, you could see that compared to the BVS, this Meril gets, because the squares are smaller, it does get easily degraded, and the other advantage is that the footprint does not get compromised, so it gives enough coverage of the endothelium so that the re-stenosis or event rate does not happen. And the light microscopy also shows that the endothelialization is also very good. OCT in rabbit iliac arteries up to 28 to 90 days, you can see these pictures, and gradually over the period of time it gets gradually absorbed. Again, this is a picture from the rabbit iliac arteries. The inflammation was slightly higher in absorb compared to the Meril 100, and that could be because of the strut thickness when you compare absorb and the Meril 100 in rabbit iliac arteries. The animal results of scaffold long-term bioperformance also, if you could see the OCT picture of absorb and Meril at the implantation time at 6 months and at 1 year, you can see that the scaffold of absorb doesn't get as it remains as big as it started at 1 year, but you could see that in Meril 100 majority of them have got almost 50% of them has got absorbed. So we had a MERES 100 clinical trial program, and first of that was 108 patients. We have just concluded MERES 1, that is first in men single de novo lesions. 16 Indian centers were included. Then they have planned for MERES Extend, like Absorb, MERES 100 Global, then MERES Evolve, then MERES 100 China, and MERES 100 US. So these are all future planning, which the large number of patients, up to 2,000 patients in MERES 100 would be included. So in total, the planning to have more than 5,000 patients included. So if you look at the MERES 1, enrollment has been completed with PI Dr. Ashok Seth. A pilot study was there, and core lab was Sao Paulo lab. And these are the investigators and investigating team, which I was at the Max Healthcare, one of the members. The key inclusion criteria was patient should be from 18 to 65 years of age, maximum of 2 lesions in native coronary arteries, but lesions should be 1 per vessel. Reference vessel diameter should have been 2.75 millimeter to 3.5 millimeter. Lesion length less than or equal to 20 millimeters. Study device should be 19 and 24 millimeter length. Stenosis had to be equal to or more than 50% of and less than 100%, and TIMI grade more than or equal to 1, so there was no 100% occlusions included, and majority all patient lesions had to be type A lesions. The patients which were inclusion criteria was patients of acute MI were not to be taken, so less than 7 days that cannot be taken. History of prior intervention, be it CABG or by PCI, that should not be. Very severe LV dysfunction, EF less than 30% should not be. Aorto-ostial lesions were contraindication. Left main disease, lesion in 2 millimeter of the origin of LAD or circumflex, bifurcation lesion with side branch more than 2 millimeter, extreme tortuosity or calcification, extreme angulation, aneurysm, and patient who had creatinine more than or equal to 1.3 milligram per deciliter were excluded. In my experience, we had done around 13 cases, and in total we had implanted around 18 stents, scaffold MERES 100 in double vessel disease also. So I'll show you one of the cases. This was first case, 36-year-old male, and a non-smoker, stable angina patient, no family history, and this is, you can see that just after a large diagonal had significant stenosis in LAD, and we implanted 3.5 millimeter into 19 millimeter MERES 100, and the result was good. The BRS success mantra is that full pre-treatment with antiplatelets, good guide catheter support, extra support wire if tortuous anatomy is there, so that you can navigate these devices to the lesion. Pre-dilatation has to be really, really good with the NC balloons, and 1:1 ratio should be dilated. The optimal or large BRS deployment, so size should not be compromised, so slightly on the higher side the size should be kept. Post-dilatation has to be really aggressive as against the initial practice that people were afraid of post-dilating, and we can upsize to 0.5 to 0.25 millimeter of upsizing with post-dilatation, and OCT or IVUS for vessel sizing and lesion optimization, especially during the learning curve. But if people have used absorb technology for long, they can bypass this step. And post-dilatation has to be really, really mandatory. And MERES Extend 1 enrolling, PI Alexander Abizade was there, and angiographic follow-up in each center is there. And the investigating team, again, luminary of international faculties are there and the lead investigator is Alexander Abate from Sao Paulo. So this will be the part where, it will start MERES 1 Extend study. The MERES Evolve also would be planned very soon, and study chairperson would be Martin Leon, and Dr. Alexander Abizade would again be PI for this study, which is, clinical endpoint would be ischemia-driven MACE at 180 days. So to conclude, ladies and gentlemen, MERES 100 technology represents an emerging BRS concept resulting in biomechanical properties comparable to other BRS and moving towards conventional metal drug-eluting stents low strut thickness, high radial force, radiopacity, high retention force, biomechanical stability, and stable molecular weight loss at long term. Animal studies confirmed the absence of thrombogenicity of the material and stability of the biomechanical properties. MERIS-1 and MERIS-1 Extend have begun enrollment, and early data appears encouraging, and the study will soon confirm the usefulness of this promising device in clinical situations. Thank you for your kind attention. Thank you once again.
So any questions from the audience? We may not have Dr. Kumar later on because he's obviously off-site and he's going to do one of the live cases. So if you have any burning questions, this is the time to ask. The question is how deliverable is MIRAS, especially if it's compared to the absorb stent?
Yeah, so it's fairly deliverability was quite good as far as our experience goes, but obviously we have not checked it into very complex lesion. But in all type A lesions, we never had to withdraw the device.
Did you, the struts are thicker than the absorb. Did you find that there were problems with subacute recoil? Or?
I think we have lost the communication.
Did you find that there was, compared to the absorb, a loss in the lumen early on due to the perhaps perceived lack of radial strength due to the thinner struts?
तो इसको कनेक्ट डिस्कनेक्ट हो गया.
So this lecture and the case. I think we lost the link. Thank you.
Can we move over to the next speaker, please?
This but I can't hear. कदू डिस्कनेक्ट हो गया.
Live case number 3, which is Dr. Agarwal.
हाँ वापस पूछो वापस.
गिर गया. I think we are disconnected. Can you repeat the question, please?
So the question was, MIRAS has a lower strut thickness compared to absorb. So did you have any concerns about an acute recoil because of the thinner struts? And did you, if so, have you noticed any?
Yes, that's a very good question. We had initially some recoil issues, especially in larger vessels. And then we felt that we had to, post-dilate it more aggressively, and we had to do repeated dilatation. Even the scaffold, the dilatation had to be kept for longer duration. So that was a little bit of issue, but not a major issue, to be honest with you. So we reconfirmed it with the imaging technology like OCT and the IVUS, and that was not an issue at all.
Thank you.
Thank you.
Shall we, we're moving over to the next live case, so it's a different panel. Okay, so we have got Adam, we have got Dr. Sparrow, we have got Dr. Agostini and Dr. Berland, please.
Hello, I'm Dr. Spiro. I was meant to give the other talk on MIRAS, but I think we're running out of time, and also a lot of it was covered by the previous speakers. But I probably was not the best person to speak about MIRAS, as I have never used it. My experience only with Absorb. And really the exciting thing about MIRAS is that the rather the Achilles heel for the absorb is the thrombosis. So the fact that it's much thinner struts, earlier endothelialization, the better opacification of the distal markers, because you have to avoid overlap. I think that's all the advantage selling points for Meril. And now we'll wait and see what the results.
So I understand we're waiting for the connection with Kaslap, yes? It's a live case. It's the last one for today.
Yes.
We have two live cases. Okay, so we have the
Yes.
very
Yes.
tough on time because two live cases is a match for
Right.
the session.
Yes, we are ready. 2 minutes. Okay.
Just
Okay.
Just to spend some time. Do you have any experience with the other valve solver on the market now? What's it, Elixir, I think, or Elixir?
There is only Elixir, I think. There is no more because Dreams is still in clinical trials and the launch will be at EuroPCR, this biotronic stent, which is a magnesium stent.
Yeah, magnesium. I used in a few cases the Elixir stent. And the advantage of it with respect to the absorb is that you can post dilate a bit like this one as much as you want. So you don't have to stay in the range as with the Abbott BBS. And also I tried in a couple of cases to recross to the side branch. It's possible, gentle dilatation in the side branch. So I think it's an interesting.
The strut thickness is similar.
It's 120, I think. So it's kind of in between this one and the Abbott stand. They tried to go to 100, but they had some issues with the recoil. So they stopped a bit the program, but they want to, of course, to downsize the strut thickness. So I'm really curious to see how this will perform because it's 100 micron is very small. So yes.
You shouldn't jail an important branch up there, and obviously you have lost a big one.
But you didn't recross.
Good afternoon.
Hi. Well,
Dr.
hearing you.
Hi,
hearing
Dr.
you.
Adams
Go ahead, Barry.
and Dr. Bernard. So let me just take you through to my team, Dr. Deepak, Dr. Pradeep, right, and all my senior technicians are here. Right. So let me just take you to the slides first. The case. First slides, please. The gentleman is about 45 years old. He's hypertensive and a type 2 diabetic. angina on exertion class 3, well-preserved LV functions, about 50% ejection fraction. Its CAG, which was done about 2 months back, 2.5 months back, showed left main bifurcation, which is 90%, and LED, which is a diffuse disease, which was difficult to treat surgically. Can we have the first slide, next slide please. Just see this. These two views are telling you that LED has got a diffuse disease. The tight points are at the ostium. The mid segment shows moderate disease, and distally also there is a tight disease. Circ ostium is also very tight. So considering the diffuse nature of disease, we decided to just go ahead with the angioplasty. Can we have the next slide please? So this was February. So first the distal stent was placed. This was a 2 millimeter into 19 millimeter biomemora with a very thin struts. Next please. And this is the bifurcation that we made with a partial crush technique. And the end result was reasonable. The guy remained asymptomatic for nearly 2.5 months. But again he had the similar
We
symptoms
almost
that he had
don't hear
before.
you. Could you do something with the voice because the loudness
You
is...
can't hear us? Okay. Can we... am I heard too loud?
If you
Okay,
can
am I
improve
too
the
loud or
loudness
too slow?
because...
Okay, fine. Hello, can you hear me now?
We hear you, but not very well.
Just slightly better, I think.
Okay, can you just improve the audio? Did you see the pictures? I'm sorry for they are coming up with the audio improvement. Did you see the last picture of left main bifurcation stenting?
Yes, we saw that.
We're not quite sure
Yeah,
what we did.
can we just go back again? Can you hear us now?
Now we see the still frame without arteries. So if
No,
you
you're seeing still
can
frame. Fine.
do a loop and see now.
Can you hear us?
Not
No,
perfect,
can you
but
hear
better
us?
than before.
Okay, I'm sorry.
No, no,
like
it's okay.
they're improving the audio.
Okay.
So this was the last picture in the last sitting, which we did about 2.5 months back.
Which technique did you use for the left main?
It's a partial crush.
Okay.
We didn't hear what
Okay.
the
So using a
LED stand was. Was it a BRS or a metallic stand?
no, it's not a BRS. It's a metallic stent. It's a Zeiss V 3.5 into 28 millimeters in the LED, and circumflex had resolute integrity 3 into 18. Right. Am I heard now?
Yes, that's good.
Okay. Next, please. So the guy comes again for the last 2 weeks, the same symptoms, which is angina exertion class 3. He can barely walk for more than 5 minutes, and then he says that angina is there. And now next slide please. So we repeated the angiogram. The RCA is a large artery with a mild to moderate disease. Next please. And this is the left system. The bifurcation stays just the same, but there's a disease progression in the mid LED. And there are 2 points which are tight. One is just beyond the first stent, and second one is just before the second stent. And there's some ingrowth in the distal small stent also.
So which stent was the distal one? And which?
It's a Biomime Aura. It's a metallic.
Okay.
Biomime Aura.
2.0.
That's a 2 into 19. 2 into 19.
Okay.
Right. So now, what do the panel says about how should we treat this patient?
I'm
Can
not
we have
sure
an
if I
opinion?
would have chosen in first instance. Now it's easy to say, of course, but I'm not sure if I would have chosen in first instance to treat PCI with this patient. Before you, I mean, with the first situation. Now, I think you started. I think I would go on with PCI. I wouldn't go for surgery personally,
Right.
because now you have only single vessel disease.
Actually, I think
So that
maybe mid and distal LAD with the Lima, but yeah, you need to have good surgeons, depending on how good are your surgeons.
okay. Okay. So now the question is that would you still recommend surgery for him now?
no, not for surgery. We'll go ahead with angioplasty.
Not for surgery.
We cannot really tell
Okay,
how,
fine.
how
So
important that second diagonal, first diagonal is.
the first diagonal is important vessel, but unfortunately it's very tight lesion. Now let us go to live shots today. Next, please. Next, please.
Do you want to touch both
Next,
lesions
please.
in LAD, located at the LAD origin, at this distal one as well? I understand, yes?
I'm not hearing you. But
You have 2 lesions in LAD, one at the side of the
Yes.
origin of the diagonal branch, and the second one below,
Yes,
which is
yes.
as well tight. So I understand you want to target both lesions, yes?
Certainly, yes.
Yeah, okay. With
Now,
2 stents or with 1 long stent? What is your strategy for this?
Just to make a room there and see that how we take this small vessel with a drug balloon and maybe do a focal stenting if the need arises. What do you say? Or you would straightway go for stenting?
I think that the risk of dissection with balloon only is much higher because it is a very severely diseased and small lesion. So, you know, in my opinion, I would prefer to stent the whole mid-LAD.
I totally agree with you. I agree with you.
Without using, because, you know,
So,
you have to check the true size.
we will do the IVAS once, as we go along, we will do the IVAS and see the actual size of the LAD. Right. So now the another problem is there once we start it. Next, please. This all-star wire goes easily into the main branch, into main artery. Next, please. Now, despite trying very hard with a slippery wire, no wire goes into the diagonal. Next, please. Next, please. And as you see, as soon as the wire is there in the LAD, the flow is less in diagonal also. Next, please. Next, please. So what I did was, I pulled the LED wire back and the flow in the diagonal improves. But still, there's no wire which can go into the diagonal. So what I'm planning now is to just dilate very, very gently with a small balloon and see that.
Can try. Do you have any angled
Okay.
microcatheter?
Like a crusade.
Yes, we have
or something like
microcasters.
that.
No, with the angle tip. There
No,
are
we-
supercross microcatheter.
no, we
with
don't have
90 degrees
crusade.
Angle tip that can help in this analysis.
For unfortunately, no, we don't have that. So short of that, I think the plan should be that we should dilate it gently and see that whether the plaque shifting is not there in diagonal, and we can wire that. Can we have a 2 mm balloon, please? Closure of this diagonal, the guy is not having any angina. The flow is almost stopped. 2 into 15.
Continue.
Short of crusade, anything else we can try?
So you have one wire in the LED. Are you planning to put the second wire already after the diagonal, or just before you balloon, so that you have the wire already kind of?
You see, I have tried the balloon. I've tried the wire.
Yeah.
I've tried a whisper wire and a fielder XTR,
Okay.
but unfortunately nothing is crossing.
No, but now you have the wire that you want to put in the diagonal. Is it already, you left it in the LED, or you just first pre-dilate and then you will go?
No, yes.
You do
I'll go.
stepwise.
I'll go with the after predilate.
Okay.
Okay. Can I have a small check, please?
No flow, you're supposed to have no flow. You're supposed to have no flow.
Okay. 1, 2,
You have to check the position of the balloon.
2, 2.5, 3, 3.5, 4, 4.5, 5, 5.5, 6, 6.5, 7, 7.5, 8. Eight and a half, 9. Deflate. Deflate. Just small check.
Right.
Yeah. Okay. Gently go 1,
2 mm stent.
1.5, 2, 2.5, 3, 3.5, 4. Deflate. You see the balloon slips down. It's a fibrotic lesion. Okay. Two and a half, 3.5, 4. Half, 6, 6.5, 7. Deflate. Let me see that how the diagonal is flowing now. I hope it flows.
Right.
Sweet.
Right. Right bar.
Check. Yeah, it's flowing. Can we have the fielder XTR? Till now it is flowing. So I'm taking an fielder XTR. which wire you would like to for me to take?
I would go for a hydrophilic one. Like I like the Sion Black personally, but you can consider
Sion Black. Okay.
I don't know if you have it in
Whisper?
India.
No,
I
Sion
don't have
Black we don't have.
experience with Whisper. You can think of a Pilot 50 or Pilot 150.
Okay. Okay.
But I don't know the other
So
one.
first let us see this fielder. A small check.
What wire are you using?
This is fielder XTR. The tip is 0.09. 0.09, sorry. Colonel, please. Small. Just a moment. Check, please. Can we have Whisper please back again? Okay, this is not taking the... You see, still there's not enough room for it to rotate. I think I have to dilate it a bit more and take a chance. Because it's just the same as it was before. Check. I'm just taking another shoot. No. Come to RA Caudal. A small check.
Would you consider putting the small balloon feathers to the lesion and deflect it in?
Yes. I think I've entered. Colonel, please. This right caudal view was showing me the ostium of diagonal, which was not seen in other views. So that was the reason I came back to that view. Caudal views again, and show me the. Okay, can we have the same tube balloon again? And then we just take a micro catcher and exchange the wire.
Take fine cross and on BMW.
Huh. So now, what should be the strategy for this small vessel LED diagonal bifurcation?
I would personally
Any ideas?
go for provisional. But
Yes, I'm also thinking like that.
But you can also decide to predilate and see
Because it's small.
how much it will grow the vessel, because it's possible that it's much bigger than we think in the end, the diagonal.
Maybe we do the IVUS in both.
This would have been ideal for a capella that doesn't exist anymore.
Or a Triton also.
Colonel, please. Now we should dilate this LED to the full. Go. 1, 2, 3, 4. 5, 6, 7, 8, 10. 11, 12. 13, 14. Any consensus about putting a scoring balloon deflate? It's a small vessel and a fibrotic lesion. No, don't remove. RA caudal, please. Because the lesion is not fully open, the proximal one. There was a good waste on the balloon. I am planning to take a 2 millimeter scoring balloon before I do the IVUS even. Or shall we decide the size after IVUS, seeing the size of the vessel? 2.5. Cranial, please. Micro ready.
Fine cross.
I personally think one disadvantage of working on a wire
3.5, 4.
like the Fielder XTR is that it's black and you don't really see good how
I know
the
that.
balloon behaves.
5, 6, yes. I'll change it
You can change for a
very
normal wire
shortly.
after you predilate maybe.
Yes, I'll do that, yes. 6.5, 7. 7.5, 8. 8.5, 9. 9.5, 10. 11, 12.
Dock.
Deflate.
Dock. इसका डॉक अलग है. It's a different dock.
RA caudal, please.
Which guiding catheter do you have? Judkins or something
Yes,
else?
JL3 7F.
Okay.
Yeah. There's a mild disease at the ostium of left main. That's why the guiding is slightly out all the time. And let me take a shot in this view now. This will tell us exactly the diagonal length. Yeah, that's fine. Dedu. See that problems. And then we need another BMW there. डॉक लगाया नहीं लगाया
डॉक से ना
हाँ तो लगा लो ना डॉक
हाँ डॉक लगाओ
इसका अलग से होता है ना दूसरा
मैं बोल दिया मैंने उनको डॉक
होल्ड द वायर इज देयर कोई बात नहीं ले लो अब ले लो इज इट देयर
यस
नहीं अब तो निकालना पड़ेगा ना
I'm not holding the wire.
Not going. PTO है क्या ये?
नहीं अभी मेन वायर नहीं.
Okay. BMW.
Dock. Let's
No, कोई बात नहीं BMW दो. And a scoring balloon. First, I think we take an IVUS. So at least we can see the size of the artery.
Which wire are you putting now?
This is BMW.
Okay.
Which one? Ah, BMW.
BMW.
BMW. And you have also BMW in the LED.
Hmm? No, LED has got all star.
So dock is
Yeah, hold, just open the tui.
How do you remove the microcatheter? With an extension or?
Yeah, I'm just taking extension. Yes, extension.
Okay.
Yeah. Okay, now give me an IVUS. Cranial, please.
It is stand at the origin of the diagonal or not? No, no. Yeah, the LED, but below. Side of the place.
Center, please. Center, please. So you guys agree with the IVUS first?
I think mainly the LED would be worthwhile to IVUS indeed, as we said before, to see whether which is the real caliber. The problem is that you will probably not have any part of the vessel that is kind of healthy, so we'll always continuously have some remodeling. So it will be very difficult to really find out with this the diameter, I think.
Yeah, I think let us find out. Then we choose the scoring balloon of the same size. Would you prefer scoring balloon or a cutting balloon?
For the LED. I think I will go for
For both, LED and diagonal both. No scoring.
I don't have it in my lab.
Do you want,
Okay,
to
okay.
accomplish in
You see-
general this procedure with two stands on, or with only one stand into the LED and then to redilate the diagonal ostium? What is
I
your-
just want one stand in the LED.
Okay.
Yeah, only LED stand, if required be. Scoring balloon or cutting balloon, whichever is preferred mode, you see the result is like very good once you see the like scoring balloon or a cutting balloon. And in my opinion, because of previous stents there in the left main and proximal LED, the scoring balloon is a bit more friendly.
You have also a restenotic lesion in the distal stent of the LED. Are you going to use also the cutting balloon inside or not? The scoring balloon?
No, I'm not.
No? Because you have a restenosis lesion.
In the stent itself?
Yeah.
No, that's a mild to moderate lesion. I would not touch that. Because this is the result also at that time also it was a hard plaque, and it gave you only that result. There was a residual stenosis in that. Okay. Is it ready? Okay.
Okay, ready?
On करो.
Flash.
Okay, This should be ready with this by time. Just okay. On karo.
On karo.
Yep, this is fine. Is it an automatic pullback? Do you have the? Give me the pullback.
Automatic pullback.
So now I've gone beyond the first stent. What did you do? Don't do that. Everything is out. Just relax. Just leave it, leave it. Let me do the manual pullbacks. Just hold it.
So it's done.
I also think that they don't need any imaging for stent pathology. That's maybe after stent.
No, there's some problem there. There's some problem there. Okay. Yep. Screen.
Yes. So you are now in the diagonal, eh?
This is the LED.
LED.
You see the hardly any diameter there.
Yeah. This is the distal stent.
And I don't think any surgeon can grab this small vessel. It's a diseased vessel distally with less than 1.5 millimeter diameter. The previous stent shows some ingrowth. Now the hair diameter looks around 2.25, maybe 2.5.
Where it gets a bit bigger, this probably starts to be a 3.
Yes, bit bigger. Yes.
But you never know if it's positive remodeling or whatever it is. It's very difficult to find the real diameter here.
And the plaque burden is huge.
There is a 3, let's say. It's good.
Yeah, in one dimension 3 or one dimension 2.5.
Yeah, here you can measure. This is probably the diagonal stenosis. It's coming to the diagonal.
The branch.
Yep.
That's the second one.
Okay.
In now. Okay, here is the second stent.
Okay. Yeah, I'm just seeing that second stent also the proximal distal segment.
So the stent in the proximal LED was 3.5, right?
Yes, 3.5.
Okay.
Yeah, this stent looks nice.
Okay. So, feedback. Would you like me to go to the diagonal also, or is it okay?
I think
we
was
don't
quite,
need
yeah.
imaging in diagonal.
You could see the osteo of the diagonal look pretty nice. Do you do manual pullback or automatic?
It's automatic pullback.
Automatic, okay.
Flush.
And the branch. Flush.
So now we quickly go into the diagonal. One IVUS, please. Fibers on screen, please. Fibers on screen, please. Short segment. Can we start, please? Fibers on screen, please. शुरू करो. Start the run. Okay. Yep. So it's 2.5. In one dimension, maybe 3 in another dimension.
I understand you measure from external elastic lamina to external elastic lamina, yes?
You mean it's larger? We are coming close to the ostium now. Yeah. Okay. Okay, thanks. So now we need a 2.5 scoring balloon.
Look, 2.5, didn't it, yesterday? When it was healthy?
Yeah. Two and a half? Okay. Would you like me to dilate that proximal portion of distal stent also? Live screen on the top. The image is small, yeah.
So now your plan is again scoring balloon in the LAD?
Yes.
Okay.
Yes. It's a 2.5 scoring balloon.
Okay. And you start just at the proximal edge of the distal stent?
Yes, this is what I'm planning.
Okay. Can you ask someone of your team to measure the distance between the two stents with IBUS? From the proximal
Okay.
edge of the distal stent to the distal edge of the proximal stent?
Yeah. 2, 2.5, 3, 3.5, 4, 4.5, 5, 5.5, 6, 6.5, 7, 7.5, 8, 8.5, 9, deflate. Okay, 1, 1.5, 2, 2.5, 3, 4, 5, 6, 6.5, 7, 7.5, 8. Deflate.
We are just commenting that we like a lot the way you let the balloon inflate with the 1, 1.5, 2. We like it a lot. We don't do it, but I think I will use it if you allow me.
Yeah, be gentle to arteries, they will be gentle to you. Go up. 1, 2.
I will quote you, don't worry, I will quote you.
2.5, 3. On the balloon. 5.5, 6. 6.5, 7. 7.5, 8. 8.5, 9. 8.5, 10. 17.5, 18. Eighteen and a half, 19. Deflate.
Last 10 minutes. Distance 10 minutes. So that is around 40 millimeters.
So now let us get now. How much is the distance?
40.
40.
40 millimeters.
39. The distance between the two stents is about 39 millimeters.
How much?
39.
39, okay.
So I think we should just go into the diagonal with the same scoring balloon. So what length of the stent we should choose? What length and what diameter?
We were just discussing here, and there is a preference for probably for a morph 40 because you have 39 length between the two stents, and probably 3/0 2.5. If I can speak
Okay.
for the group.
Do we have morphed 3 or 2.5? 40? Check.
What is your plan?
Let me just tally the diagonal, then I'll, check. Check. I'll be just at the ostium in the dilated segment. Small check.
Ready.
Okay, 1, 1.5, 2, 2.5, 3, 3.5, 4, 4.5, 5, 5.5, 6, 6.5, 7, 7.5, 8, 8.5, 9, 9.5, 10. 10.5, 11, 11.5, 12. Twelve and a half, 13. We have an option of 2.5 3 into 40, that is 2.5 distal and 3 proximal and 40 length. And we have got an option of 2.25, 2.75, 40. Different.
There was even some doubt that the proximal part of the LED after the stent would be even bigger than 3, or approaching the 3.5. So.
So 2.5 into 340. Okay. Give us 2.5 into 40.
2.5 3 into 40.
For 2.5 into 3, sorry. 3 into 40. Diagonal ostium is well open but well dissected also.
प्रेशर देखिए नॉमिनल कितना 9 nominal बहुत है
Now, another question will come whether you remove the diagonal wire before you deploy the stent. It is not tracking. Recorder, please.
Yes, yes. What do you think is the problem? Is the stent in the left main LED, or is some tangling of the two wires, or combination?
Maybe tangling of the two wires, because one is BMW. It's always tend to tangle.
You managed to get balloons down.
In any case, I have to remove the wire before I deploy the stent, because I can't keep it between the two stents. So, shall I remove the wire
I think you should safely remove
from
the
diagonal?
wire from LAD and come back again.
Come back again.
From diagonal, no.
No, maybe you can even consider a very early use of a guideliner to pass the first stent. Depending.
You
I
see,
mean,
the
if you really
proximal
think
stent
that the tangle
is.
is the problem, then probably I would also remove the wire. But if you think if you're not
But you
sure,
see, in any case, because the you see, the proximal strut. So I have to remove the wire in any way once I'm deploying the stent. I can't keep it inside, otherwise it will entangle.
See your point. Fair enough.
Or I take two short stents. I think I would just let me try short stents first. Achha, give me a 2.5 into 24. Two and a half and 24, Aura.
from the last attempt that you made, looks like the stent stops at the level of the passage between the left main and the LED, if I'm correct. Or does it stop further down?
No. There's a bend there in the LED when it takes off from left main,
Okay.
and the other stent is stopping.
Okay.
So let me try a smaller one because the bigger one is not going. Just a moment, just a moment. Can you please? This tracks down. Center, please. Now, would you like me to cover the old stent a bit or not?
What size is the stent? Sorry, I missed that.
It's a 2.5, 24 by my Mora.
I would put it just in proximal
Okay,
overlap.
let me just
with
take
the
it.
previous stent then.
Yeah, I'll just do a proximal overlap a small bit. Is it okay? Is it fine, or shall I pull it a bit more back? Okay, I think it's okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 is the optimal deployment pressure for the aura. Deflate. And we'll measure the length also before we take this out. Okay, go up. 6, 7, 8, 10, 11, 12, 13, 14, 15, 16, 17, 18. Deflate.
Next one here. 3 into.
Now, let me take the measurement for the next one.
390.
Okay, 319, please. Last shot, please. बात छोड़ दो. Okay. Are you recording? Any suggestions?
Guideliner, I think also guideliner at this level. I really think that the problem is the proximal stent. So if you can pass
Yes.
that with the guideliner,
Not the proximal
then
stent.
you can anchor. You can anchor with the balloon this, and you bring the guideliner in. It's the guideliner, I think, will pass.
Can we have another wire, please?
ACD.
Another all-star, please. Or give me a BMW. BMW.
Would it be possible to have a look at the echo examination to see if there is maybe under expansion of the proximal stent already implanted, the proximal LED stent?
That we have seen, that already we have seen on IVAS.
Slightly inflate this area, then it will be much more easy to cross and to cross with the secondary stent, you know.
You see, already we have seen on IVAS, there's not much of the like under expansion of the proximal stent, and the ostium of the LED is pretty wide. So I'm just taking a buddy wire first.
This is the same center or another center?
I don't know. I don't know if it's the same center, but I was said it's possible to. It is New Delhi.
Crane, please. Yeah. Higher quarter, please. Let's make sheet update. Yeah. I'm not very happy with the jutting in a guide liner, shoving into the left main stand. That's why I'm trying a simpler way if it can happen.
You're doing a body wire there, or not sure.
Yeah.
Try to bring the guiding more deep into the. In the end, you have a stent in the left main, so you can also push the guiding deeper and see whether if you can torque it a bit into the ostium of the LED.
I'll try that.
Deep seating.
You see the LED left main here has got a slight up curve.
Is the premium cement. This is fine.
So it is the previous system.
Nice, you're true.
So this one worked. Crane, please. Now the question remains whether we should remove the diagonal wire before put the stent in or not.
I wouldn't personally remove it. It's a BMW.
You will not remove it or remove it?
It's a BMW wire.
Yes, it is.
So you don't have any issue with
Yes.
polymers and stuff. I would leave it there personally.
You're not looking between the stents shorter.
It will be locked. See this?
There's only one layer, so.
So if it is, then you have to keep that.
Now you have a little bit of overlap proximally, but
No. I will pull it out because I'm not comfortable in jailing this wire between the two stents. And we'll see. Okay, go up. 1, 2, 3, 4, 5, 6, 6.5, 7, 8, 9, 10, 11, 12, 12 and a half, 13, 14, 15, 16, 16 and a half, 17, 17 and a half, 18. At 18, this becomes nearly about 3.36. Deflate, please. There's no ST elevation, patient doesn't have any angina.
There's a little indentation at the bifurcation.
Yeah, I see that's all dissection there. It will be very difficult to recross this diagonal now. Trying to rewire this diagonal, we might close it up completely.
Yeah.
I would leave it like that. And it's a small vessel and it's closer is not causing any problems. Let me have a 3O non-compliant balloon.
What is this?
Mm-hmm. Three-O, fast. हाँ 3 हाँ दे दो 15 दे दो ना 15 quick. So we are just going with the 3O high pressure balloon.
So it was decided not to purchase this.
I think they're moving us to the other cat lab. It looks very nice. Very nice result. I think we're going to be moving on. Have to see the final result later.
Okay.
Do we have any connection with this CAS lab or not yet? I think with this CAS lab, which was
5, 6, 7, 8.
transmitted already, just
9,
to
10,
congratulate the case
11,
or
12,
not?
13, 14.
I think they deserve applause in any case, even if they don't hear us. It was a nice case. Yeah.
Just to speak about this case, in my opinion, I would be much more aggressive for pre-dilatation of the medial AD, and I would use the high pressure 3 millimeter balloon, and maybe also try to redilate the first proximal LAD stent implanted to facilitate the crossing of the long, very long stent that was planned to use at the first time. So I would be much more aggressive in pre-dilatation when you need to use this very long stents. You have to prepare the lesions. You know.
I also think that, in my opinion, Judkins left guiding is let's say, suboptimal for these anatomies. I mean, you want to have support right away, so an extra backup would be or an plus left 2 or 3 would be more.
You know, we stopped using this curve only for osteal lesions, osteal left main. Otherwise, we are using extra backup for the whatever the lesion we have on the left. On the left side, we are using the extra backup. Only for osteal lesions.
Or very small anatomy. If you have very small women, sometimes the extra backup is too big. You need a Judkins left like 3 because it doesn't fit anything else. But very few cases, very. Just for just for curiosity, in the audience, how many people have experience with the biomorph stent? Clinical experience. Did someone use the long tapered stent in your routine clinical practice, or just raise your hand? So nobody.
Only one.
In my cath lab, but a few cases.
Okay. No, but just 1 or 2 is enough, just to know who has a bit of experience.
This, I think, a niche device, in fact, because how many patients we have such conditions.
Yeah.
But useful, of course.
With CTOs and ideal, actually.
I think CTO is probably the most reasonable.
You would have a long dissection, and much easier to carry out.
Hello.
Yeah.
Can I just pass a comment? I think in that case, if he used a guideliner, he could have got the long stent. And his concerns about damaging the left main stent, if you have the stent protruding just out of the guideline, like the nose of an aeroplane, you can kind of advance it without causing trauma to the inside of the stent, I think.
I think if you think also from an economical perspective, in this procedure, in the end, the operator decided not to put the stent, so in the end, one stent is lost, and you lose the money of the stent. He put 2 stents, okay, he succeeded in that, but if you would have tried and succeeded, of course, with a guideliner, put the long stent, it will be a cheaper procedure.
So 2 stents less,
yeah, 1 guideliner more, but 2 stents less. In the end, it's cheaper procedure.
Depends to the price whether you get the guideliner, which is not so, which is expensive, you know.
No, it is an expensive
So I'm not sure that it is not maybe the same price than
as 2 stents.
Than two stents, you know.
Cheaper than the stent, I think.
I'm not sure. For me, for my institution, I'm not sure. I think about
I think the guideline in my institution should be around 400 euros.
400 euro, but you can get a stent for less than 400 euro.
We paid more in our institute on the stent. But 2 stents, in any case, 2 stents will be more expensive than a guideliner, even if you pay a stent very cheap.
I think he was worried you damaged the stent, but I think as Ramesh says, the stent is worse than the guideliner.
For the guideliner, we are using lots of the anchoring distal technique that you mentioned before, you know. This is very effective, specifically in right coronary artery with the Bishop curve, you know, Cook curve, you know. We are using a lot.
And if you have like in this situation with the stent, this is a very nice place to anchor the balloon.
Because the risk of dissection is relatively high with a guideliner. If you want to push the guideliner only with the support of a wire, you may dissect, you know, the proximal artery. So we are using a lot. Because we have two improvement: the fact that you anchor the system distally, and the fact that you push on the tubing of the stent of the balloon, of the distal balloon, which gives you a better support and better trackability, and you have less force to do.
Yeah, sometimes you don't even have to anchor. It's just enough the shaft of the balloon in the artery to make the system more stable and bring the guideliner down. Your experience with the other types, because now there is a guideliner, there is Godzilla, there is
We have the
Gideon.
Godzilla and guideliner. We agree with it. We have also, but we have not experience for the other systems.
As a feeling is the same, Godzilla and
Yeah,
guideliner?
yeah,
You don't see
yeah,
major differences?
yeah.
You use it...
We had before the Cherimo system, which was a long, very long
Yeah, the
mother and child system. We started. It was bulky, it was difficult to move, and it was, so we start with this system, mother and child.
That was a lot cheaper.
We're supposed to stop.
Two lectures.
We're supposed to chat.
There is someone from Saudi also.
Shadowing? It's from what? It's from UK. It's from UK?
Yeah.
But you have a lecture.
No.
No, you
So
have
my lecture has been cancelled because they gave me the same slides anyway.
So there is a lecture of experience with
From UK.
Get one of them to give the talk and stop and leave. He was just here a minute ago.
Yeah, it's coming.
Do you want to start your presentation anyway?
Yeah.
Yeah, because there is a problem.
You may have to stop.
But 47 seconds.
47 seconds.
One, 1.5, 2, 2.5.
70 is enough for a lecture.
Sir, angiogram after angiogram after this type of thing.
Just give the talk.
Sorry? Hello, good afternoon, Dr. Kumar. I am Dr. Berlin from the Meril. We are running the session from the Meril Institute. It was a great pleasure to see you again because we saw you a few minutes ago. I am with my colleagues, Professor Witowski from Poland, Dr. Spirou from UK, and Dr. Agostini from Netherlands. We are changing your case, and it's a great pleasure to see you again. And you can start to present the case as soon as possible. Go ahead.
Hi, good afternoon. It's a real pleasure to be with you this afternoon in this Meril Live case. And I would first thank the Meril people for giving me this opportunity to do the live case. And I welcome all the elite panelists and chairpersons for this case. I'll introduce first my team, Dr. Vivek, again, he is my colleague consultant here, Dr. Ravi, and then our chief technician, Sushil, and then we have got staff nurse. All of them are helping in this case. So I'll request Dr. Vivek to briefly introduce the case.
Thank you, sir. A very good afternoon to everybody there. I'll just give you a brief case summary of this patient. This is a 60-year-old gentleman, an active smoker with no history of diabetes or hypertension. He had been operated for a carcinoma thyroid about 10 years back and underwent a radiotherapy for that. He is not cured of that. He presented to us with 7 days history of unstable angina with rest angina uttering for the last 24 hours. He was hemodynamically stable. And this is the ECG of this patient. We can see that there is a biphasic T wave as well as deep inverted T waves with a preserved R wave, indicating a proximal LAD lesion and a preserved myocardium probably. And his echo, this is the second ECG in follow-up. We did an echo screening of this patient, and he had a EF of about 35 to 40%, and troponins were mildly elevated. And so we did an angiography, and Dr. Veda will further elaborate on the angio shots and the plan of treatment. Thank you.
So this is the patient who had, recurrent angina. In fact, he had to take 20 tablets of sublingual nitrates while he was coming to the hospital. And can we show the yesterday's angiogram? We had done a cath yesterday, and he had almost severely narrowed ostial LAD, and there was significant plaque at the distal left main also. These the guide catheter we have taken just now before we start became live. You could see that is a bang ostial left anterior descending artery. There's a huge artery type 3 LAD, and no wonder he was having severe rest angina. Because the ischemia is showing repeated ventricular ectopics as well. Can you go to the next view, the cranial view? Yeah, so this is the patient minus. The moment we wired, the flow in LAD stopped completely. So we had to, and patients started having angina. So you could imagine how critical this blockage was. And you can see that dye was sticking in the proximal part of the LAD. So next, we have just done a balloon dilatation with 2.5 into 12 millimeter balloon at 10 atmospheres. Next slide. So you can see this is place where we are. So this had restored the flow, but you can see that the LAD was quite big artery, and there is some spasm in the proximal part of the left main. You could see if you compare from the LAD to the left main, there is, left main looks a little spasmodic, and LAD looks almost 3.5 to quarter to 4 millimeter size vessel. While we were waiting to go live, again, next, the flow in the LAD again became little sluggish, so we had to give, intracoronary adenosine and diltiazem and nitroglycerin. And then, can you show the last picture?
Does he get chest pain?
Yeah, so next.
With the slow flow?
Yeah, so after this adenosine, this flow returned to normal. We gave a lot of adenosine and diltiazem, and the flow is, so this is the place where we are now. So again, next we wired the circumflex also, because This is now the position. Can we have a shot again?
So your
So
femoral
this is the
7
current position
French?
now.
Is a 7 French catheter or 8?
Yeah,
or
femoral 7 French. Yes,
7
yes,
French.
yes.
Extra backup.
No, so this is 7 French femoral catheter.
Okay.
Yeah, extra backup. So this is the position where we are. In fact, we intended to do IVUS, but the moment it connected, it's just not working. Hopefully, as the case progresses, the IVUS would work, and then we can show you the IVUS images as well. But it's as of now, we are just not able to, boot the machine for the IVUS machine. So I would like to know from the panelists that what would be the strategy in dealing with such a huge LAD, which is bang ostial and distal left main also significant disease. You could see carefully the circ ostium also has probably some thrombus has migrated into the circ ostium with the proximal most part you see. So their strategies could be, the bang ostial stenting vis-a-vis coming into the left main and stenting the whole thing together. So I would just like to know the panelists what would be their approach. Can cranial please?
The last patient I had like this, I pre-dilated quite a bit of the ostium and then implanted a biodegradable stent. I'm not sure if you have a big one. I'm not sure what the size is.
But you cannot going up to
Nitrogen.
you can go up to 4.
So it looks like a 4O, so I think we would use a drug-eluting metallic with. But left main could be even 4.5.
So you put the stent on.
So would you cover the whole left main, or you would come?
Okay.
Plus.
I mean, you could stent from the left main into the LAD and this.
Yeah, I mean, you can pause the late.
So we have given some vasodilators.
I wouldn't honestly choose for a BVS here because in the end, you don't have the issue of the surgery in the future at this level. One issue for me that is nice of the BVS is the distal lesions because then they disappear and the surgeon can eventually operate there. No, but it's because we just start putting the BVS, so we have to wait a couple of years that they
we have to
disappear.
wait 5 years.
That they disappear. They're still there. Yeah.
Epicaudal.
But I think the big question.
I have a question from the audience.
Yeah,
Is
sure.
the right okay? We haven't seen any problem in the right coronary.
Right is normal, yes. So right coronary is normal. Can we show the slides previous?
But I think the big question here is
right coronary is normal.
Is whether who would go for let's say ostial LAD stenting, trying to stay at the edge of the LAD, or who would go for a left main LAD stenting, covering the ostium of the
Yes,
circ.
yes.
I would personally go for a left main LAD stenting, covering the ostium of the circ.
Yes, yes. So that's what we are planning to do. So can we have a 4 millimeter stent?
Yeah.
480.
423. 424. So this is the Meril stent Biomime Aura 4 into 24 millimeter, cellular coated stent. So what we would do is we will go right from the left main covering the ostial LAD and then, do a pot in the left main.
It is 40 millimeters,
4.0, yes.
4.0 by what length?
by length.
24.
24, okay.
Yeah.
No, it is biomime.
Yeah, so it's a
biomime.
drug-eluting metallic stent with bioabsorbable polymer. So this is time-tested stent from Meril Life Sciences. We have used more than 3,000 stents of this Biomime Aura stent, and that's very good. Long-term results are also very good and proven. And since it's a left main, I think we would prefer metallic DES rather than because there is no issue of future uses for the stent, the bypass graft site and all those things are not an issue.
And with the 4
So can we have a
stent,
check shot? Yeah. It has got also the mid segment has got open cells, so probably the side branch access would be much better, though in such a big vessel that's not been an issue.
It would be nice to see. It would be nice to see this angio in left anterior oblique view, just to see if
Yes.
your stent will cover the ostium of left main.
Yeah, that's right. So LAO, left anterior cleavage.
LAO, not RAO.
That's nice.
Yes, yeah.
Yeah, like this, something like this. Yeah.
So it's covering right up to that place, and the distal
A
segment
bit
is
back,
reaching up
it
to
is
the
our suggestion.
diagonal. Big. Yeah.
It is the
So I think a
suggestion
bit
of the
millimeter we
advisory
will
box.
draw. Yeah, check. Yeah. Okay, so this is the place where we'll deploy the stent. Can we go? Inflation?
He's fast. He's fast up there.
So this is a stent which inflates from the center and goes to the peripherally. 12, negative.
the 4 millimeter stent will grow up to
Areocranial.
if you wanted to have her expand the left main stent part.
So at 12, what is the size? Can we have the bar?
Show there.
So
4.15.
Yeah, so at 16, it would go to 4.4. So we will withdraw it little bit in the left main and do a slightly higher pressure. Okay, can you go to 16, please? 16 atmosphere. Okay, negative.
I personally think I wouldn't have
Check
put the
shot,
wire
please.
into the circ. I don't know what would the other have done, but I think
Yeah.
that because of the ostium of the circ was so free of disease, now you have the issue of
Yeah,
the
that
jail
was
wire.
clean, but there was some. There was a
It will be
suspicion
easy
of
to remove
thrombus, so
this
that is
wire,
why
I
we
think.
put. Yeah.
But I don't
Yeah,
think it's really
absolutely,
needed
yeah.
to put it before. You can just put the stent on one wire
Yeah.
and then put the
Discuss,
second
yeah.
through there.
It looks that it is free of disease. So.
Yeah. So
Now
we'll
it may be
remove
the
the.
discussion.
You can
should
see
we
that the side
open
branch is
the
coming
struts
quite
into
easily.
the circumflex or not? You would.
So we'll just have a look.
And
How
what
does it
about
look
the
like
pot
in
only with, for example,
in short, please?
4.5 and not opening the struts into the circumflex?
I would do both.
You can see the strut looks good.
Because it's a very big circumference. The struts would be, I mean, if you don't dilate them, it would be significantly smaller.
Dr. Kumar, there is
4.5
the
balloon.
discussion among the panelists. Would you like to open the strut in direction to circumflex or not? Or just do, for example, only a pot with 4.5 balloon and just leave it as it is? What is your strategy in such case?
So technically, I would say that some amount of opening should be better, so that for future disease we can access this if suppose, though it looks so clean that it's very unlikely, but I think ideally
You
we should try and
re-engage the
open that.
circumflex, so I understand you would like to open the struts. Because
Yeah. Yes. But we will do a first pot and then see how it goes.
Do you try to pass to the distal
Can
cell
we have-
closer to the carina, or just
Yes.
the first that
Yes,
you get
yes.
you go through?
Yeah, so we tried that it should be, yes. So it's always better to have, from the distal cell. So what we are doing is we are taking a 4.5 milliliter balloon for pot. And
4.56.
Stent boost. So we can take help of a stent boost also. Just show the, can you zoom on the stent boost? Okay. Go up 8, 10.
So what is the size of this balloon? It is 4.5 or 4.5? 6.
Yeah.
Non-compliant, we assume.
Non-compliant. Yeah. 12, 14. So this is 4.5 balloon and we have inflated up to 14, 16 atmospheres. We'll take the help of a stent boost to dilate the proximal most segments as well. The stent boost, please. Yeah. So proximal most struts would also be dilated. Go up 10, 12, 14, 16.
You want to check in IBUS the results of your stenting?
Yeah, so that's what our plan was, but IVUS is yet not getting booted. So we have connection with IVUS, but after the first shot, the IVUS has stopped working right now. So we are just hoping that by the end of the case, probably IVUS would start functioning. We'll take a shoot now and see. So there circumflex also. Can you show the cranial? Well covered, and the stent is nicely positioned, ending just before the diagonal. Can I have a balloon of 2.5 for the side branch?
Could you imagine the spider view?
So this is the spider view.
Just the stent.
Was published a few months ago. You have less than 20% of positive FFR with this kind of image.
Yeah, so I think technically FFRs would be negative in this case.
They are not treating the vessel.
My idea to recross and treat the ostium of the circ is not for the angiographic result, but it's more to know for myself for the future that I know that I can cross, you know?
Yeah.
Because sometimes I had a case where it's difficult
because
to
in
get the balloon
future
down and stuff like that, and that is nice to know right away. For me, it's perfect. I was just like and inside the
2.5 balloon, yes.
just to be sure that I can pass for the future. That's my only idea, but it's not
So that's what I feel that
I think we are working with very large inflation. Don't need to use a small balloon.
Yeah, but if you use a standard
system, you can see.
Dr. Kumar, what is the size of your
also? And then finish by doing a. So it doesn't look can be done. I think there isn't enough data now to treat these with drug balloons. Do you have any experience of that? Anybody in the panel?
Can you repeat, please?
Anybody's experience on that?
I
Yes.
ran with colleagues a
0.5.
randomized trial, not in left main, but in
4.5.
bifurcations. But it was with the a couple of years ago
Hmm.
on the market. So I
Mhm.
think
with a drug elliptic balloon systematically inflated. May have
Yeah,
some
yeah.
space with this drug elliptic balloon for bifurcation, and specifically Frenchman invasive balloon, but it was the equivalent.
Support of that. So since we have distorted the strut while going into this So this is again the same balloon. Go up. Negative. Printing last. Done.
You've got a lovely result. It's very nice.
Good, thank you. So we'll remove the wires and take final shots. Some nitroglycerin.
So you decided not to go for IVUS, yes? Just do the final.
No, that's
test.
not yet booted, so I think performing. Is the IVUS ready now? Not
There's
yet?
some technical problems with that.
There is some technical issue with the IVUS machine right now.
do you routinely perform this kind of
But
procedure where
ideally,
you just,
this is the end result.
I think that
So
it's,
unfortunately, the IVUS is not working. We would have soon.
you choose a 4mm stent for the distal left main and proximal LAD, and it was absolutely right, because when you look at the result, most of the physician undersize a little bit, the stent, and it is very important. Even for the LAD.
Or the oversized stent tapering kind of segment in the left main, and the LED we can keep at 3.5 to 4 millimeters, so we don't go very high pressure. So you can see the LED is also very well dilated. Left main looks beautiful. I wish our IVUS was working right now, but it's not yet.
Very nice case, really. And very well done.
Thank you very much. Thank you.
Very nice result.
Thank you once again. So this is all we have from here. And thank you once again to all the panelists and audience. Thank you.
Bye-bye.
Dr. Chadoui, please. Next presentation would be current update on bifurcation stenting.
Okay, can you hear me? So this is a new gadget for me, and hope this works. Okay, that's great. I don't have any conflict of interest related